one. Check. Hey, hey. Check. One, two. Check. One, two, two. Check.
serum creatinine was 1.5.
Hello. Hello. Good morning, everyone. We will be starting the second day, the first session, Amulet Symposium. I call upon the moderators, chairpersons for the session, Dr. Ranjan Shetty, sir, Dr. Bharat Vijay Purohit, sir, Intervention Cardiologist, Hyderabad, and Dr. Ramesh Dagubati, sir. And Dr. Rahul Rohit Mathur, sir, HOD, Government MDM Hospital, Jodhpur. Please come up on the stage, sir.
Hello, good morning. Yeah, so we will be starting today's show. Thank you very much. So, we would also, after this discussion, we'll keep some time to discuss on how to take it forward. So, unless you have a flight to catch, please don't leave and be in the hall. If there's flight to catch, they will organize your travel. So let's start with the first session. I think it's a recorded video from Dr. Balbir Singh, and he will be joining for any question and answers. Yeah.
1 years old, permanent atrial fibrillation, post-op CABG 18 years back, was on apixaban and doing well until recently when he presented with bleeding stools. His hemoglobin had dropped to 7.3, necessitating 2 blood transfusions. His serum creatinine was 1.4. Echo showed a dilated left atrium, normal LV function. And fortunately, upper GI and lower GI endoscopies were normal. So most of the times when a person bleeds on drugs like apixaban or rivaroxaban or dabigatran, we tend to see that some of the tumors come up and they have a colonic cancer or a colonic polyp which bled. But in this case, everything was normal, and now it was a dilemma as to if we stop apixaban, there's a very high chance of a stroke, and if we continue apixaban, what is going to happen to the hemoglobin? So, as if most physicians take a defensive step, so they discuss with the family, and most of the family members are not keen on such a procedure. It's not like angioplasty, so you have to discuss many things, and many of them are not keen looking at the age and other things. So, the simplest answer which most physicians do is reduce the dose of apixaban, which is not a great idea. 2.5 milligram twice of apixaban is not a great idea because it has problems. It has problems which can be risky and in terms of stroke, and this is not the recommended dose. However, in this patient, again, the same decision was taken. The family thought 2.5 milligrams. Let's try it for 2 weeks and see. And he was sent home on 2.5. However, within a month, he had another bleed and was readmitted. So now there was no choice but to go for a LA appendage closure procedure. So this is one of the most ideal situations to do LA appendage closure in this setting. So LA appendage closure procedure involves a T, which is absolutely essential. A CT can be used for guiding the size of the device and looking at a clot. However, in this patient, the creatinine was 1.4, so a CT was not done. The procedure is always under general anesthesia. It has to be a groin puncture of the right femoral vein because that's the easiest way to access the left atrium. It's always ultrasound guided. In our case, we try to be very careful in this puncture. We use the right radial for pressure monitoring, and if an angio is needed, we use the same site. We don't do a groin puncture for any pressure monitoring or any angiograms in this patient. A property in the lab or before the procedure, a day before the procedure is important because you have to rule out an LA appendage clot at that point in time, LA or LA appendage clot. And looking at various angles on T is the key to looking carefully at the appendage and clots, if any. So you do measurements, you do the leg depth, the lobe measurements, the clots, all these things on T. Now, understanding the appendage anatomy is very important. That it can have various shapes. So it can have shapes which can be very varied and can be anatomically challenging also. The second important thing is that the appendage has some environment, other structures. So you have the pulmonary trunk right across. You have the circumflex artery, which is going right behind it. And then you have the left superior vein on top of it. So you have the left superior vein on top, the circumflex artery behind, and the pulmonary trunk on the right and above. So these are the friendly structures around the appendage, and look at some of the appendage anatomies which can be very, 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 very. So if you have cactus, cauliflower, chicken wing, windshark, do you change your procedure? I don't think that really truly matters for an amulet device because it is placed proximally. It may matter for uh, watchmen, but not as much as for amulet. Now, there is one example here where this is a windsock appendage, but it is pointing upwards. Here, the sheath tends to point downwards. So, in such a situation, an anti-clockwise movement on the sheath can make it go towards the appendage, upwards, and make it coaxial. So, coaxial placement of the sheath is extremely important. So this is how an amulet device looks like. It has a disc, a lobe, and some stabilizing wires. So the lobe fits into the appendage, the disc outside the appendage. And in this case, you can see the lobe has fitted quite well into the appendage, and the disc is lying outside, covering the appendage mouth. So these are the wires which tend to stabilize the device on the appendage. And this is the lobe which fits into the appendage. So there's a gap between the lobe and the disc. And you should see this gap when you have deployed. They should not appear as if they are fixed to each other. So there's some amount of gap. It's always good to see because that means you have done a good job in this um, closing the appendage. So other thing that is important is that look at how this device fits into the appendage. And this fixing means that it is very well aligned. It is parallel to this lobe. It is not coming down like this. If you have a malaligned lobe, it has two problems: leaks, and the second problem is a displacement of the device from the appendage and we just embolize. So that is the second problem of malalignment. So you have to be very careful with. You may take your time. You may change your position. You can pull in, go back as many times as you want, but be satisfied that there's no malalignment and the disc is outside the orifice. Now, T based sizing is important because most of the times we do that. CT based sizing is easy, it uses a 3 Mencio. A perimeter derived mean diameter can be calculated, the maximal diameter can be calculated very easily. The T based involves that you look at various angles and see where you get the best mouth or the orifice of the appendage and then measure to your best choice. So where do you measure? So you have measurements at two levels. Three measurements are important. So first you have to identify in two different angles. So you see that two different planes are there. This is from the top of the ridge. So this is the ridge. This is called the Coumadin Ridge or the Warfarin Ridge. Why is it called a Coumadin Ridge? Because earlier this head that you see on the ridge was thought as if it was a thrombus, and many reports were that this is a thrombus actually. But then it was realized it's not thrombus; it is a ridge. So once you realized it is a ridge, the name was kept as Coumadin Ridge. So you measure from the top of the Coumadin Ridge to the end of the appendage hair. The second measurement is a few millimeters down, top of the circumflex artery, draw parallel line, and cut the appendage. So these two are important measurements. The third measurement is the depth of the appendage. So it has to be at least 10 millimeter to make you comfortable with your lobe sitting into the appendage. Otherwise, the lobe will jut out. This is another method which we use routinely now, a 3D measurement of the appendage orifice. So you see, we mark 4 dots. We can calculate the perimeter. We can calculate minimum and maximum diameters and take an average of this. So this is another way of looking at the same thing. For example, in this patient, an average comes out to be 1.3, and we size the device 13 millimeter beyond this. So now we have few more things to learn on amulet device, how to use, what size to use. So we have sizes between 16 to 34, and we have depths which need at least 10 millimeter. We have the disc diameter which is at least 6 millimeter more than the device lobe diameter, and we also know the lobe length is generally 7.5 to 10 based on the size of device. So up to 19 device size, 12 French sheets is enough. Beyond 19, a 14 French sheet is always better. And when you measure the width on the landing zone that I showed you with the yellow dots, you add 3 millimeter to that to calculate what device size need. So this chart is very important, that you choose the right size. You have measured the right size length. Now you choose the right size of the device. This is a transeptal puncture. This is totally T guided under general anesthesia. This is an SL1 sheath. So we are hardly using Mullen sheath. We use a SL1 sheath, and the puncture is inferior and in the mid. So for mitra clip, it is inferior and posterior. For TMBR, again, inferior and posterior. For this, it is in the middle. So this is an SL1 sheath. We confirm by giving small amount of contrast in the side, and after the puncture, we change the sheath by taking a long exchange wire, generally an Amplatz wire, which could be placed generally in the left superior pulmonary vein, and we exchange that to the custom sheath given for the amulet device. This is the sheath, and it's so nice that you can just turn it around on T and point it towards the appendage. So it has a tendency to go upwards to the left superior vein. You can point it downwards. Always be coaxial. Use a pigtail to push it beyond the ostium. If you're going beyond the ostium, use a pigtail. Don't go with the sheath past the ostium. LA appendage is very notorious. If it ruptures, it doesn't close. You have to go for surgery. Very rarely does it close. It just keeps bleeding because there's no muscle in it. So you have to be very gentle in getting the sheath. This is the most important part of the procedure. So if you go beyond the orifice, use a pigtail, because the pigtail is the softest catheter to do that. We always guide this with both 3D TE and transesophageal echo. So you see the orifice and you can guide the sheath towards the orifice like this. Once you have done that, first is to get the lobe in at the right position. This is completely T guided. Just fluoroscopy just gives you an idea that you are there. Fluoroscopy also gives you an idea that you're at the at the coaxiality to the limb. Now here is the T showing you that this device is not properly aligned. It is good that it is beyond the lobe is good inside, but it is not properly aligned. And 3D T, this is not a aligned lobe. You can see this one. We are the lobe is not well aligned to this. This lobe is little bit twisted, so you can always go back. So go back and do. Now this example is a 3D showing you that the disc has nicely covered the orifice of the appendage, and you can see the orifice is completely covered. And once you've done that, we do a tuck test, and if the tuck test is fine, we release the device. Now, this is the final picture. The device has been released, and you see no leak at all. And this is the 3D picture showing you very properly aligned device. And no leak whatsoever. And finally, you can take a shot to see where your device and the disk are.
Dr. Balbir, welcome. This is from Bangalore. Can you hear us? Offline. Yeah. He went. Okay. So this was Dr. Balbir from the Delhi, and he showed a case of amulet. And so the steps are, now we are going to start a amulet symposium, because in India we just have three devices, and as we discussed, all of them have their little bit tips and tricks. You could choose any device. All of them are safe, but each of them, it's more about understanding them little bit. This is different. It's not like one more stent. When you put one more stent, there is no real learning. They only say tracks and things like that. But here, there's a little difference which comes. So it's better to be device specific and you learn. But we are going to have more sessions on this. Now there is Dr. Devi Nair, who is live from US. She's going to show us a live in box. And then Dr. Purohit here is going to show a live in box. So we could have a lot of discussion with that. Then imaging will be shown by, I think, Dr. Yeah, so we're going to have an imaging session. So let's hand over to Dr. Devi Nair. Dr. Devi Nair, are you online? Yeah, yeah, yeah. So over to you will be, please go ahead with your presentation. We'll reserve our questions to the end. Thank you for joining us. I know it's a Friday late evening for you. Thank you. Absolutely. Thank you for having me. I'm just waiting for the host to enable screen share. Sure. That- Share on screen here. Well, thank you very much, Dr. Shetty, for having me at the summit. Sorry I'm not there in person, but hopefully I'll get to meet all of you in person at the next meeting. Let me see. I'm still waiting for the Zoom sharing to be allowed. Can you see my screen? Dr. Devi, we can see your screen. Yeah, yeah, yeah. So, here is the recorded case of an amulet implant, and I've obviously edited it down to about 15 minutes so we have some time for discussion.
I would request Dr. Ashish Jha to join on stage. Dr. Mukul Kumar, Interventional Cardiology, Thanda. Dr. Ramachandra, Interventional Cardiology, Hyderabad. Dr. Naveen Chandra, GS, Interventional Cardiology, Bangalore. Dr. Rajat Sharma, Senior Cardiologist. Dr. Siddhnath Singh, Interventional Cardiology, Bihar. Dr. Akshay Pratap Singh, Senior Cardiologist. Dr. Siman Srivastav, Interventional Cardiology, Chhattisgarh. Dr. Miraj Rao D, Interventional Cardiology, Hyderabad. We request all of you to come on stage, doctors. Kindly join on stage.
Please let me know when I can start. Yeah, yeah, Dr. Devi, sorry about the interruption. You can start now, Dr. Devi. Yes, yes, yeah. Thank you very much. So, what Dr. Balbir gave a very elaborate presentation on the steps of amulet implant, and I'll try to show some of those steps during this recorded case. This is a patient that actually was referred to us for LA closure for jab bleeding, had an elevated CHA2DS2-VASc score and an elevated HAS-BLED score. They were currently taking aspirin and Eliquis. So this is a procedure that we did under TE. We sometimes do high statins, but
this is TE guided. You can see, like Dr. Balbir said, it's very important to look at the appendage in different angles. So usually we look at 0, 45, something around the 90 plane, and something around the 135 plane. So mainly you're looking at a mitral valve cut, an aortic valve cut, and a pulmonary artery cut. So the pulmonary artery sits here, and this is one of the views that I look to see how close the pulmonary artery is to the appendage. So the idea is that you are getting different imaging at different imaging planes, and then you want to do your measurements. And here's an example of how the measurement is done with both the disc measurement as well as the landing zone measurement. You can see I'm doing the velocity as well, because that's something I keep in mind as I land the device. So here we had a 30 by 26 measurement, and again, that's the orifice measurement. But we also sometimes do CT, and then Dr. Balbir mentioned about using CT and Dementio. This is a different software called the FIOS software. FIOS is a little bit different. It does this automated segmentation of the left atrial appendage. So, we get a pretty decent idea of where things are. So here's the circumflex. Once we upload the CT, it does this automated 3D segmentation, gives us the disc measurement and the landing zone measurement, and you get the max and minimum, so you can get an average dimension, so you get to pick the right kind of device. And here you can see we are seeing a 26 by 22 landing zone, which kind of puts us somewhere between a 28 device, a 31 device, or a 34 device. And you can decide what you want. And the beauty of this particular system is also allows you to help with transeptal. So if you can kind of tailor your implant to the transeptal, and majority of those implants, like Dr. Balbir said, is usually inferior and mid-transeptal, but again, you can assess this. Now, the other thing this software does is it allows you to actually do virtual imposition of these devices. So this is we're taking a 28 device and we're trying to put it in there. This is a virtual simulation, and this yellow and red colors are looking at apposition scores. So yellow means you're touching, red means you're not touching. So it kind of gives you an idea about whether you're going to be able to put this device appropriately. So you are, the idea is that you're coming prepared with all the solutions. And here, this is a 31 millimeter device that has been put distally. You can see the frame deformation of what that device is going to look like. You can see the mitral annulus, how it's going to look. And this seems like we have a pretty good position there. That's a 34 device, and you can see that's a much bigger compression. So I also look at the proximity to the pulmonary artery, because the angles of the amulet device are a little bit more longer. So I'm very cautious about what the pulmonary artery location is as well. So here we're getting started with our access. You can see we are doing this under TE guidance. Again, I get my access with ultrasound guidance. Like Dr. Balbir said, there's one thing, if you can avoid, is a vascular complication. You'll see that we're using the steerable sheath for amulets in this case. Since the steerable sheath has been launched, we are a completely steerable sheath program. You could use the regular sheath, and there's nothing wrong with it, and just switch to a steerable sheath when you have a difficult case. But in our practice, we have kind of gone to just going straight to the steerable sheath. And what you're seeing me do is a co-close. So we actually do the steerable sheath is a much larger French. So it's about 19 French orders. So we'll do a double co-close, and we pre-close it ahead of time. Again, we send our patients home the same day. That's something that that we've adopted since 2018. So it's part of the same day discharge protocol that we have. Again, that's not something that is mandatory that you have to do. This is something that we do. So you can see I'm doing a double close, usually at a 2 o'clock position and a 10 o'clock position, just to overlap that venous puncture. Now, our patients here come on completely uninterrupted anticoagulation. So that's one of the other reasons we do vascular closure. Now, if you are interrupting the anticoagulation, you just have to make sure that you get your ECTs high, at least about 250 before you get anything transactional. So here, I'm actually using a VersaCross wire. It's a loop wire. It's an RF transceptor wire. Again, that is our practice. This is something we incorporated into our practice for all transeptals. So what you'll see me do is go in with the VersaCross wire. This is a pigtail loop wire, and that's a VersaCross sheet. It's similar to the I would say SL1 sheet, but the dilator is you can shape the dilator. It's a true form dilator. So that's that loop wire coming up into the superior vena cava. And once the wire, the advantage of the loop wire is that you can get into the vasculature directly from the femoral vein with that loop wire. So it's almost, it comes down to being a very minimal exchange kind of situation. So here I'm coming in with that was across sheet. This is just an 8.5 French regular sheet, just like the SL1 sheet that Dr. Praveen showed. So here I'm coming down from transeptal. You can see it's a T-guided transeptal. What you're seeing here is the TE here. This is the SVC over here. You look at that, look at my T images. This is RBC. So I'm coming for that inferior approach, and then I'll explain through there and to make sure that I'm in a mid location. So aorta sits right here. So you want to be in kind of an inferior and mid position to attack that appendage, especially if an appendage has got a anterior or mid kind of location. So here we have made that transeptal. I'll actually cross with the loop wire. Now, if you don't have a loop wire or a Torrey wire or a Safari, then you probably need to put a stick into the pulmonary vein and then cross. Now, with this loop wire, that is one of the other advantages that we have, is we use this loop wire instead of the pigtail, we use the loop wire to cross. So there's a lot of steps that we skip because of this loop wire. So those are some of the advantages for us with this pigtail. So what you're seeing here is me getting this wire into the pulmonary vein. And before we get into the pulmonary vein, we'll try and get an angiogram. So I like to do my angiogram with this sheet. With the current, especially with the amulet sheet, doesn't have a valve and you have to get a TUI. And so we just do it with this sheet. And you can see the angiogram here. This loop is about 24 millimeters. So that's another thing that we do is we use that loop wire to kind of size the angiogram as well. So I actually draw my screen. So that's what you're seeing. You see, what to draw on the screen. And you can see that loop is, we're seeing something in the 26 by 28 range. So when we see something like that, we can see there's a posterior kind of takeoff, the chicken wing that kind of goes backwards. But we're going to be limiting our implant to this location and not going any deep because the amulet implant does not need to be deep. So at this point, I'll take the wire out of the appendage. I don't like to leave things in the appendage as an exchange or get the device prepped. And with that sizing that we've seen, so far we've seen sizing anywhere from 25 to 28. That takes us to a 31 millimeter size. And even on our simulation, that's what we saw would work. And so the 28 would work as well, but would have a lower compression. So here I have the wire parked in the left pulmonary vein, and I'll be coming in with that steerable amulet sheet. So you'll see me come in with the steerable amulet sheet. The steerable sheet looks very similar to the Gillis sheet in a sense, but it does go anywhere from a 0 degree to a whole 120-degree rotation. So you have both flexion and extension on the sheet. And in this case, I probably will be using a little bit of flexion, but not as much extension because that appendage is got a very kind of posterior takeoff. So here I'm coming in with that steerable sheet. Again, you can see the wires coming out, snow valve on the sheet. And we're kind of crossing into the left atrium while the wire is still in the pulmonary vein. And you can see I'm pulling the dilator back. Again, like Dr. Balvi showed, I think it is easy if you get at least the tip of the sheet into the orifice of the appendage. Now, if for some reason your sheet falls out and the sheet is in the left atrium, you can always enter the appendage with the amulet roll configuration, but I will try to get the sheet kind of coaxial and oriented in the orifice of the appendage, and that's what I'm looking here. And you can do that in 3D as well. But here you can see we're putting the sheet just at the orifice. There's circumflex on my TE imaging there. So I'll put it right around the level of the circumflex. So not really deep in the appendage either. So at this point, I'm getting ready to attach the device. The device is prepped here, and we de-air the device pretty well. So here you'll see us connect it. I'll tap the air out and de-air the device. And I'll take the time doing that because I think that's very important, especially if the left atrial pressures are low. Now, this patient's left atrial pressures were measured at about 18, which is adequate. So your sizing is something that you want to keep in mind as your left atrial pressures are low as well. So if they were low, I would be upsizing the device a little bit. But in this case, since we have CT apposition done before and virtual implanting done before, we know that in CT we are not hypovolemic during the CT, and we are probably sizing it appropriate. So here I am opening the TUI, If you look at the camera, and I'm slowly advancing the AMOLED device through the loading tube here. And we'll make sure we're watching for any kind of air. And you'll see the sheath is sitting at the ostium of the appendage there. So as we're coming up, we have flush flowing, and here the device is kind of coming up. And I'll make sure my fluoro angles are set where I can see the back end of the AMOLED device to make sure that everything is connected well. So this shows me that the connection is really good as well, and the bottom here. And here I'm coming into the ball configuration. So the ball configuration is something you get by unsheathing. So you unsheath into ball, so you're never pushing anything out into the left atrium of the appendage. So once you unsheath into ball, you can see I locked my 2E. Now I'm going to move this whole system as single entity. So I'm going to counterclock it into that appendage, and I'm watching it under fluoro, but really under TE guidance. So I'm getting it past that circumflex. And when we do that landing zone measurement, something to remember is that that measurement is at the middle of that lobe. So if you did your landing zone measurement here, you ideally need to go past where you did your landing zone measurement. So to get that lobe to land where it needs to land. And then the question is, how do you want to orient it? And you can see the pulmonary artery is right here in that 135 angle. So I want to keep it off of the pulmonary artery. So I will deflect it off of that pulmonary artery to make sure that the anchors are not getting too close to the pulmonary artery. So you can see I've deflected it down, and I keep it off of that pulmonary artery before I come to the next configuration. So the next configuration after the ball configuration is the lobe. And to get to the lobe, the first one is a triangle. So I'm pushing the lobe out. So there's no unsheathing at this point. So as I push it out, it goes into a triangle. And you'll see that very well on the TE. There's that triangle. Once you're in that triangle configuration, you can push towards the back end, and it allows you to kind of deploy the device. And it's very important to deploy it very slowly to allow for that device to conform within that appendage. So here's the SIR. You can see the lobe. And what I do once I deploy it, maybe usually now, this is that CT simulation that we had, just showing you what the lobe was supposed to look like. So I'll quickly look at where the lobe is, because one of the criteria before release is the close criteria, and the C of the close criteria is to say that the lobe is 2/3 past the circumflex. And once you put that disc, sometimes it's very hard to see. So this is a good time to assess your lobe. So what I'm doing here is I'm doing an X-plane on the 90 and the 0. I'm also giving an angio shot to make sure my orientation is good. And this kind of shows me that my appendage is actually occluded already. And so this is where that dual seal comes in. So the lobe has already occluded the appendage, and now the disc is going to be the secondary seal that I come up with. So I can clearly see my lobe is 2/3 past the circumflex. Now I'm getting ready to deploy the disc. So at this point, I'm unsheathing. And once I'm about 2/3 past, then I'll slowly kind of push that disc forward. Now, what you see on the TE is that disc is under the pyramidal ridge. And that's not something I like to see if I can avoid it, because it creates a recess. So what I'll do is I'll make a room for that disc to be pulled out. So it's almost similar to having a tension test. So I just pulled it back and realigned it on top of that pyramidal ridge. So here now the disc is sitting nicely on top of the pyramidal ridge. So while you deploy that disc and while you do that tug, or it's not really a tug, it's really the tension test, you want to keep an eye on that lobe and make sure that lobe does not move, or the shape of the lobe does not change. And that tells you about the stability, and that's very, very important as well. So I'll do a quick angiogram here to see. You can see that the angio is quite directed towards the mitral side, but you can really see that, there's pretty good closure there. I also had an angio of the lobe to begin with. And now I'm doing color, and you'll see I'll spend my time waiting for imager to do color at different angles. So we'll go through the entire 0 through 180 degrees to make sure that we have no leak in any angles, and especially the high angles. And we want to make sure that the disc is nicely opposed onto the left atrial wall, because you don't want to have a leak between the disc and the lobe either. So those are some of the things that we keep in consideration as we do that. Now, one of the things that the advantage of the steerable sheath is now in this case, I could potentially actually extend that deflection and make it a little more coaxial. But again, I don't think we manipulated it as much, especially once the disc is out. I try not to mess with it a whole lot. And you can see the color was good, so we're getting ready to release, and I'm kind of counterclocking about a couple times out of backward tension to pull that forward wire back in. And here you can see we have released the device, quickly making sure there's no pericardial effusion, everything looks good on the TE, and they'll do a 3D image after I release. And you can clearly see now the disc is sitting over the Coumadin bridge with that lobe past the circumflex. And you can see that fine angio where there's clear occlusion of the appendage with good apposition of the disc to the left atrial wall. You see contrast going through the fabric past the disc, but that is again through the fabric, and that will eventually stop as well once the appendage completely thromboses. And here the images are getting some good 3D images. The one thing I will caution people is I would be very careful about assessing the leak in a 3D because once the disc is out and you do 3D, everything will look closed. So I think it's very, very important to assess closure with the lobe before you put that disc out. Also, doing it in 2D plane to check for that leak is also extremely important. So here we're getting our sheet removed. We already have close in place, and we'll close that off and finish with that. Now, the criteria that we look for before release is a close criteria. The C in the close is that the lobe is 2/3 past the circumflex, and that's the most important criteria. If the lobe is not 2/3 past the circumflex, you run into the risk of embolization. And so this was that apposition that we saw, and that's something to kind of keep in mind as well, is to kind of make sure that lobe is nice and tucked in. The L is lobe compression, which you can clearly see there's compression in the lobe. There's a distal puck, and the screw is off axis. You can clearly see the compression as well. The O is orientation, which is, you want to make sure that the disc and the lobe are oriented with each other. And then S is the separation, separation of the lobe and the disc. If there's no separation, you don't have that anchor point. You don't have the elliptical nature of that disc. And E is the elliptical nature. So you want to satisfy your close criteria before you release the device. So with that, I will stop. That is the end of that session. Doctor, thank you very
Yeah.
much.
Um, Thank you, Dr. Devi Nair. Could you hear all the applause from the hall? It was amazingly done. Everybody is very happy here. Yeah. So it was what we were. It's almost perfect textbook like. There was, each step was very well explained. I have just one or two questions. Then I'll pass it on to my co-chairs and the panelists. So, do you have a preference? How do you choose when do you use amulet and when do you use other devices? Yeah.
So, like I said, actually, I think 80% of the appendages, you can use either one of the devices. A lot of this in the U.S. It really depends on the contract and all kinds of stuff. But beyond that, I think thinking about using the device, I think 80% of the regular appendages you could use either one of the devices, and you will get away with it very well. Now, there are certain advantages to the AMOLED device because it has a dual seal technology. And because you have that lobe and disc configuration, there are certain anatomies that I prefer the AMOLED device. Now, one of them is the chicken wing anatomy, especially anterior and posterior chicken wings. And the advantage of the chicken wing anatomy in AMOLED is that you could use what's called a sandwich technique, where you put the lobe as an anchor and use the disc as a seal. So if you don't have depth with the chicken wing, if it's a narrow or a shallow chicken wing, you can use the AMOLED, and it does really, really well. The other part that I like the AMOLED device is if there's a lot of proximal pectinate, especially along the Coumadin bridge or along the mitral annulus. If they're very proximal pectinates or very proximal lobes, that's where that dual seal, the disc, actually will help you get that more optimal coverage. Because if you do a plug device alone, or if you just do a Watchman or any kind of plug device, then you leave those pectinate areas uncovered. And again, there's a lot of questions about how relevant that is and whatnot. But I mean, the whole idea is that we take care of all those pectinate tissues. Now, there's two anatomies that I try to avoid an AMOLED device. One is if the pulmonary artery is very close, especially in a patient that has pulmonary hypertension, and if the PA is enlarged, and if I see that the orientation of the appendage is towards the pulmonary artery, and the distance between the pulmonary artery and the left atrial appendage wall, where I will be putting the device, or where the lobe will be sitting, is less than 2 millimeters. So in those cases, I avoid it because the anchors are a little bit longer, and there is concern for PA injury. The other anatomy that I avoid down the device is a funnel-shaped appendage where it's nice and conical. So in those appendages, especially if the left atrial appendage velocity is very high, then I don't like it, the device, the lobe tends to kind of get pushed out. So and I tend not to use the Watchman in those as well, or the amulet in those as well. The Watchman also really doesn't do as well in that anatomy. I'll tell you the best device for that anatomy used to be the legacy Watchman, the 2.5 Watchman, which we don't have in the US anymore. So that's kind of how I pick and choose.
Thank you, Dr. Ramesh is here. He's yeah.
So, Devi, good evening for you. Actually, it's probably around night time for you and ready to go to take a nap, I guess. So, let me ask you, in your center, how many of your patients get LAO CT imaging?
So we have the program set to have the pre-imaging done in about, I would say 70% of the patients get CT imaging before. And maybe that's for, we have a protocol where we do the imaging, we do the pre-planning software, we do the analysis. And so we come pretty prepared. Like I already know what the anatomy is. So I have access to both the devices on my shelf. We also have multiple clinical trials that are happening. So we get to kind of choose the device based on the anatomy. Sometimes, we would choose it also based on, what's safest for the patient, especially as I was showing you about the PA and stuff. But mainly it's based off of the anatomy. And then the other reason is mainly the efficiency and the workflow that comes with it for us. Because then we get to kind of, we have appendage closure days. We don't intermingle them usually with other cases. So it's a much easier setup and it's much efficient for us to do it that way.
Any other questions?
Yeah, thanks, Dr. Devi, for a nice presentation. I just wanted to make a comment that your handling of that curved wire, loop wire safari was really marvelous. But having said that, you made it look easy. I suppose that it's something which needs expertise. And to begin with, I think it would be really good if we take this pigtail, the wire, and then, because this handling, you made it look easy, but I felt that it requires expertise. Thank you.
Oh, I completely agree. Like I'm going to do it with the Safari. I will tell you that was the VersaCross pigtail wire, which is a little more softer loop. Before the VersaCross loop was available, I was 100% pigtail user, so I used the Amplax wire into the left superior pulmonary vein. I'll put a pigtail in there. I will not enter the appendage without the pigtail. Now, the only one thing I will say is that you potentially, if you did fall out of appendage, you could actually enter the appendage in the amulet ball configuration. But in the ball configuration, that distal puck is still exposed and it's still traumatic. So you have to be extremely cautious as you enter the appendage. And as previously mentioned, the appendage is not a very forgiving tissue. So you have to be extremely careful and be watchful of the imaging.
Any questions from the, yeah.
No, no questions. Thank you, Dr. Devi. Excellent. You taught us two new things. One is VersaCross, which Dr. Dagubati mentioned yesterday, and the software. The software, I think it's amazing. And one question is, when the appendage is closer to the pulmonary artery, you said you would avoid amulet. What is your next go-to device?
So it depends on the orientation of the appendage with the pulmonary artery. Sometimes we end up using the Watchman Flex device in those cases. In rare cases, if it is actually super close, especially if it's what we call the type 2 anatomy, where the proximal part of the appendage is very close to the pulmonary artery, and the proximity is throughout the length. Then sometimes I'll send the patient for a fluoroscopic AtriClip.
Thank you.
Thank you, Dr. Devi. I think you have one more talk with us, so we'll come back to you. Do you want to? I think this go later.
Yeah.
So thank you. We are going to come back. Thank you. So
Thank you very much.
please.
Yeah. Well,
So next talk will be live in box talk, Dr. Bharat Vijay Purohit.
So good morning, everybody. And you saw how an amulet is deployed just like a textbook, but in real life, many times we are not that fortunate that we will be getting this picture perfect septal puncture, picture perfect deployment of the device, and even the groin puncture also many a times will end up in trouble. And when we try to push something, we find that there's a lot of resistance and we have to overcome all those things. So I think we have seen in the last 2 days so many device deployment which have been almost like textbook like. So I'll be showing a case here where things were not so easy for me, and how we overcome them because of the design of the device and the design of the sheets and delivery sheets, all those things which helped us overcome all these difficulties, and final result was good in my opinion. So, but before going into to the procedure, first let us understand what are the things we should be having in our cath lab before we start the procedure. So that it becomes a little easier for us to, because it's a little late. So I'll be just skipping some of these initial introductory things. So, so when you start a LA appendage in your cath lab, you must have certain things with you, like you should have all the basic stuff present in your cath lab, and so you should be having two sheaths. Nowadays we don't use the arterial sheath, but most of the beginners they use it because we take aorta and the pigtail as our marker for septal puncture. So a 5 or 6 French sheath and then a 8 French sheath for the venous puncture, so that we have all the larger sheaths going through that. So, but before going to taking the actual bigger sheath, we always keep a 8 French. Then you have the 50 cc syringe, basically to de-air the device when we are putting it inside the loader, and then putting it inside the delivery. No, it's not required. I'll just go ahead. And then you also should have a 20 cc syringe, basically to give contrast to the side port of the sheath. And then your regular O32 wire for the going into the vein, and then Amplaz super stiff wire, so that you can push your sheath, the Amplaz sheath into the pulmonary vein, so that. And then you also need these big bowels in which a lot of heparinized saline should be there, not the normal saline, so that you can load the device back into the loading cable, and then you can put it inside the sheath. And then you should have the broken bro needle and the Mullin sheath. Many a times people use SL sheaths also, but I have been using Mullin sheath and the broken bro needle from our BMB days since long, so we are more used to that. But it doesn't matter, whichever sheath you are having, you are comfortable with, you can use that to do your septal puncture properly, and then you can proceed with your procedure. But only one thing which I will tell you is, suppose the patient has a huge RA because of the TR, then probably you need to make a bigger curve in your Mullin sheath, or you can take a BRK1, which has a little bigger curve, so that you can actually reach the septum. If you go with the regular uh, broken bro needle, you may be struggling to do a proper septal puncture. So if you have a huge RA, you can always take that. And if somebody is trying to learn and understand how to do a septal puncture, there was a wonderful article which came way back in 2015 by Dr. Nayak. So it was a review article on transseptal puncture which came in Indian Heart Journal. So if you can go through that, it is a nice demonstration of all the steps which you generally take, including the videos. So the supplements has the videos, how it looks in the RAO view, how it looks in the LAO view, how it looks in the PA, in the lateral view, and how are you going to do the septal puncture. So all those detailed stuff is there in that Indian Heart Journal article. So I'll recommend that all of you go through that, so that it will be easier to do a septal puncture. But of course, that was written when we were trying to do all the BMBs, but that still holds good if you are going with a conventional one. So this is so this was a 80-year-old lady who had 3 episodes of CVA. One, she had a hemiplegia, and then 2 more episodes of TIA. And after the CVA, she was diagnosed as paroxysmal atrial fibrillation, and she was put on apixaban at that time. But despite apixaban, she still had 2 more episodes of CVA, and that is where we discussed with the family that what are the options. Many a times we switch over from apixaban to conventional anticoagulant, but in this patient we discussed that you are on apixaban and still you had 2 more episodes of TIA. There is this option of using LA appendage closure because she is an 80-year-old. So if I try to add an aspirin or something like that, maybe it will cause more bleeding. So just the option was discussed in detail, and they preferred that okay, we are ready to go with the device closure here. And we did a CT, and this is the CT images you can see here. It was done, and here you can see the landing zone here is coming around 16.4 millimeter in this, and so this is the you can play with the CT, and you can judge what exactly is your maximal diameter and what is the mean diameter from the perimeter. Also you can get all the information, and then you can decide what size you are going to take. So we had a landing zone of around 16.4 millimeter. So probably we decided that we'll either go with a 20 or a 22. So we will take a final decision on that based on the T also, and as well as the fluoroscopy. So this is what we had done the pre-planning. We kept our table ready. We had already had an idea that this is what kind of a device we are going to choose, because he was a 80-year and most of the patients are 80. So it is always better that you come prepared into the cath lab before you start struggling there with the T and spending more time. Patient who is anesthetized and 80-year-old fragile lady, you are trying to do too much of thing. You want the procedure to be quick and simple so that you come out of the lab quickly. So CT always helps in this case, and provided the creatinine is forgiving to you. Now there has been a lot of discussion. What I've understood is that we have decided divided this pre-procedural imaging into 2 eras: pre-COVID and post-COVID. Pre-COVID, whenever I used to attend these conferences, most of the time they were relying more on TE. But since the era of COVID, whether it is the publication of the articles or it is the COVID which really prevented people to do more TE before procedure, the reliance on CT has grown exponentially. So nowadays, the reliance on CT is more, but still the final decision comes when you are inside the lab with the T on table, and then you deploy the device. You see everything on T. Yes, it is properly apposed, or if whether it is undersized or oversized, what is going on. You ultimately take your final decision based on T only. So this is the first step. You do a femoral vein puncture, and you take a O32 wire, and you go into the left brachiocephalic and subclavian vein, and you can see how tortuous it is. So that's what I was telling, that it is not always very easy. Now in this patient, so after this, you see, I have not taken a pigtail here because we are not doing too much of the, we have not given any anticoagulant here. I only give 2,500. That's an individual choice. Some people give after the septal puncture, and some do half before and half after. So I always give 2,500 before the septal puncture and balance 2,500 after the septal puncture. So this is my Mullin sheath, which has already gone in. And after this Mullinsin, I have taken the pigtail in the non-coronary sinus. So the reason I have taken a pigtail I'm showing you here is, nowadays the T has almost removed the use of arterial puncture and the use of taking a pigtail as a marker. But we are all used to doing BMBs, where we always used to take the help of the pigtail and decide our puncture. So it's just a safety mechanism for all of us. If you are comfortable with T-related septal puncture, which we are doing nowadays, most of our cases, so you don't need this arterial line here. So, but if you are comfortable and you are starting your cases, then it is always better to be safe. And in the septal puncture also, there are various things mentioned. Some say you take AP lateral, some say RAO, LAO. It's a personal preference. Whichever way you are comfortable and you have been practicing it, use that way to do a septal puncture. And most importantly, you must see where you are doing the septal puncture in the T also. Otherwise, you will be in trouble. So you see here, the T is already in place. And with the help of the T guidance, we did a septal puncture, and you can see we are already inside the left atrial appendage. Left atrium we are already entered in. So after that, the next step comes is the analyzing the appendage. Now you can see here, uh, I have taken the pigtail through the Mullin sheath, and you see how it has taken a different curve. So we thought that we were absolutely fine when we did the septal puncture, and you can see the Mullins went shade when the dilator was in, it was absolutely pointing towards the appendage. But the moment I removed the dilator, the Mullins flipped down, and when I was trying to take the pigtail, it was not going into the appendage, and we were really struggling here. And you can see the puncture probably was not, and this is how it looks in the RAO caudal view. You can see how it has taken an abnormal shape. So this is where the importance of double curve sheath comes. So here it was not a picture perfect. We could have done a separate puncture here, but I thought maybe we can just go ahead and see whether we will be able to do a good job, even if the puncture is not absolutely where we wanted it to be. So we have first gone into the appendage, and this is the RAO caudal. We take a 30-20 RAO caudal, 30-20 RAO cranial, and you can see here the anatomy here. And we again in this also we found that the size of the septum is size of the landing jaws is coming around 16 to 17, somewhere like that only. So this is the RAO cranial view, and here also something similar. So the next step is basically to go ahead and do the introduce the sheath, and for that we had to go inside the left upper pulmonary vein with little bit of manipulation. We went into the left upper pulmonary vein, and you can see my ampla stiff wire is in the left upper pulmonary vein. So the idea is you are in a vein which is quite large, and you have taken your stiff wire and you are trying to introduce almost 12 French or a 14 French sheath into it. So if you do those things, and if you are trying to do all those exchanges, you need to do it in an organ where it is really forgiving. If you try to do all those things in a appendage, yes, if you are little experienced, you can still do it, but inadvertently, if you are not holding your wire properly and you are trying to push the sheath through the groin, and while doing pulling, pushing, if the stiff wire perforates the appendage, then it's a big trouble. So that's why we always recommend then you start doing it in the appendage. But if there is any trouble, if you are finding it little difficult to enter into the pulmonary vein, then you can do it in the appendage, and you can do it even in the left atrium also. So don't struggle too much to do all those things, because the whole idea is the process should be less traumatic than you are not supposed to create more complication by trying to do everything as per the textbook. So, but we had gone into the left atrial, left superior pulmonary vein, and here we are trying to take the ampla sheath there, and we have gone into the so after that uh, uh, when we tried to push the device, we had taken a 20 millimeter device based on the TE. When we tried to push the device in, you can see the device has flipped down and it is not entering into the appendage. So this is where the whole trouble started, and we tried to manipulate the device with the help of the sheath. We have created a little ball there, and we are trying to go in, but we are out of the appendage and we are still in the LA. So you can see it clearly that the ball is still in the LA and the mouth is quite higher up. So we need to do a little bit of anti-clockwise. So we did a little bit of anti-clockwise and try to enter. So this is where, and somewhere you can see here, somewhere here my associate colleague said, no, I think we have already entered in the T, it looks good, so let us release. I said, no, this is not the place and this is not the orientation. Yesterday you might have heard about Dr. Hazra talking that your device should be at the 2 o'clock position. It should not be at 12 o'clock, but here we were at 12 o'clock. So I said, okay, let me show you how it looks when you, because unless you do it, it is difficult to believe. So I said, okay, you release it, let us see how it looks. And you can see here, when we released it, it is absolutely off axis. You can see here the device is, this is the mouth of the appendage, and the device has been deployed absolutely 90-degree perpendicular to that, which is absolutely wrong. So, uh, so that was the initial deployment. So I knew that this is not the correct place, but because my colleagues were insisting, no, no, let us see how it looks. And with the forward push, they tried to release it, but it just was not in the proper position. So we recaptured it and tried to go again. And when we tried to go again, what we did is we did a little bit of anti-clockwise, and instead of opening the device outside, we pushed our sheath inside the left atrial appendage. And once we had entered into the mouth, we didn't go too deep inside, but when we entered into the mouth and we were seeing in the T that we are just proximal to the left circumflex, that is where we started releasing the pushing the device again. And you can see here, uh, after this, now you can see here, the device is now more, this is the circumflex and you are now more aligned to the appendage. But of course, you can see a big tension here. So we had to be a little careful when we were trying to deploy the device, because it's a very small, smallish kind of appendage. You don't have much to push it deep inside. So this is where you can see how much anti-clockwise I have given, so that the sheath which was looking somewhere like this, it is now going up, and you can see the lobe has been properly deployed, and here it looks more towards a 2 o'clock, 1:30, 2 o'clock position. And this is what is a proper position where you can release the device. And we saw that in the T also it was proper. And then we release the disc also, and you can see here with a forward tension, because if I lose my tension, again it will become off axis, because I had given a lot of anti-clockwise to the sheath here. And make sure that you give anti-clockwise to the sheath, not to the cable, otherwise you will get you will unscrew the whole thing. And that is where, with the forward tension, I was unsheathing, and then you can see here the disc has been released properly, and it took a perfect shape here. And we reconfirmed it in the T also, and you can see it is absolutely perfectly placed here. And the axis is perfect, the sealing is perfect, and we did a tuck test also. And so this is the tuck test. You can see we have just pulled. You don't have to do the wiggle here, Minnesota wiggle. You just keep a tension and just watch for 30 seconds or a minute, see whether the device is coming out or not, and you give a little push inside to see whether it is getting displaced inside or not. And if you are happy, just leave it and release the device there. That is where we did the angios. There was a perfect seal here, nothing was going in, it is just the fabrics through which we can see something is going on, and then we release the VIs. And you can see once the device is released, the tension is released, and you can see the disc has automatically gone in and it has sealed the mouth perfectly. So this is how relatively not a picture perfect septal puncture, but because of the way the sheaths have been designed, we could still get away with doing a better job than what we had thought of initially. If we had little difficulty in doing this, then I would have definitely gone for a second puncture. So we just did 2 or 3 manipulation inside the appendage, and we were able to get inside. Thank you very much.
I think very nicely done. It's not an easy one, and actually showed that how to come out doing a shallow. It's not very deep, right?
Yeah, it's a very shallow left atrial appendage.
Yeah. So, but perfectly done. Congratulations. Yeah. Any comments from the audience? Any questions? Yes. Can we get a mic, please?
Pardon? I didn't get you. Next puncture. See, I think I was a little bit more towards more anterior. The inferior was okay. I think I was a little bit more anterior here. That's why we were going more away from the appendage rather than going towards the appendage. So if I had gone into this puncture was done by the associate, not by me. But of course, it doesn't matter, because even when we have done also many times, when you try to puncture in, the needle slips, and the place where you want to puncture, you have actually punctured somewhere else, because it's not always the needle enters where you want to puncture in. So that is why this new concept of this using a radio frequency ablation and cautery and all those things are coming up. And if you have a very thin septum where it really accommodates your needle, then you are in dilemma where exactly your puncture will be. So you should be prepared for all these difficulties when you are doing it. You may not get, and many a times you have a very thick septum. So when you try to do the septal puncture, suddenly it gives away and you have a perforation of the left atrial appendage in the distal side. So because of this, the technology is evolving and we are coming up with newer ways of doing the septal puncture. And one of them have already been, I think in last 2 days, we have heard the Versa wire, which is being used mainly by the electrophysiologist, the cautery, the RF, all those things are coming up to make our puncture absolutely where we want to it precise and do our procedure. And this 3D rendering which is coming up nowadays, which will tell you exactly at which part of the septum you are going to puncture, is also going to be a great innovation, so that you can superimpose it on your fluoroscopy and you can decide where exactly you want to do the puncture. So those things are going to come up, and it will make the procedure much more simpler and safe.
Yeah, Dr. Purohit, I think, yeah, here. Yeah, I think that was a great case. And you could manage even when you were not very coaxial. But I would say that, yeah, as you said, that recent advances have helped us a lot. You can take that deflectable edge sheet that can help
Yes.
you a lot in these kind of cases. So, but rightly said, and a great case. Thank you.
Uh, a question, Dr. Purohit. So with such shallow kind of appendages and what Dr. Devi was showing about the conical LAs where the device tends to get pushed out, what if like you are not exactly two-third beyond the LCX? Your lobe is sitting, you can see the compression. Would you be accepting of it?
See, as per our book, the lambre is supposed to be beyond the LCX. The amulet is supposed to be two-third inside and one-third outside. And we all know that sorry, and we know that the amulet lobe is quite thick. So if you feel that the amulet will not be sitting there, if it is 50-50, maybe if it is 50-50, I can still accept it. But if it is less than that, then I will change over to a different device. Maybe a lambre I will take rather than this.
And in the case that you were showing in one of the views, when the final position ultimately came out to be good, initially in one of the views, it seemed, at least on the posterior superior side, as if the lobe was coming somewhere near the ostium. So how do you decide while implanting, when just the lobe is deployed, that ultimately this alignment will be a good position?
See, when you are doing a TE, you have to take the help of TE when you are doing all those things. So when you are inside the left atrial appendage and you have partially released it, you still have the ball, cotton ball kind of a thing, which is there, which is just protruding out of the sheath. At that point of time, before making it triangular, where you have to be sure that the lobe is sitting exactly on the left circumflex, and that is where you try to push. Many a times we feel that when you push, you are going to push the device deep in there. It will not happen like that. Wherever you have started pushing it, the device will stay there only. It is not that the device is going to go away, because the moment the device gets released, it just comes back a little bit. Which you can appreciate better when we were using these ACP devices. We used to think the device is going to pop in, but it will not. The moment the device gets released, it will be staying where exactly it is. So don't get afraid that you are trying to push and keeping the sheath there, and you are trying to push, the device is going to dive in. It will not dive in. It will stay there. So make sure. So slight off axis and on axis, it is mainly because of the presence of the cable which is there, as well as the sheath which is there. Because these devices are going to reorient it as per the how the LA append is going to accommodate them. So we need not worry about it. As long as we feel that it is on the circumflex, we will still able to get a good axis the moment you release the device. They will automatically reorient, and you can see that happening. Once I
Yeah,
released
exactly
it,
my
the
question.
device
So it
reoriented.
looked off axis when the disc has yet not, in your case also.
No, if
when-
you see here,
So,
it was not
this
that
case, this case was a very complicated case. Anatomy-wise, this was one of the toughest. So what you had here is a very narrow neck, followed by immediate lobe, which was flexed, which was going the other way. So that's what this case had. So when you have a very narrow neck, it's very difficult to focus the
Yeah, you
device
see
there.
here.
So this
It is
is
not that
almost like a
bad, that
sandwich.
off axis here. This is the mouth.
We
not
can't
seen.
we
It's
can't
not
just see.
showing, Doctor. Yeah,
Not seen on
it's
the
okay.
screen.
It's not
Okay,
showing.
sorry.
So there was a, the only way to put it is a sandwich. Means you put the lobe that side. That's what he got at the end. The lobe was
Strawberry
on
kind
that
of.
side. Yeah, the lobe was on that side and the disc is this side. So if you have a literally no neck like this, or it goes and suddenly you see a branch. Sometime it flexes this side, sometime it flexes towards PA. He had a flex towards PA. So the best is to go in, put the this lobe there, bring out and put the disc. So that's called the sandwich technique, which was Dr. Devi Nair. So with the amulet, again, these are all very device specific things. With amulet, you can have a strawberry, you can have a sandwich, or you can have the classical implant. So what Dr. Devi Nair had was a classical. It's called tire shaped. The device gets compressed, beautifully positioned. There is at least 10 millimeter, area where lobe is there and the disc comes and sits. That is very classical, like pacifier. But sometimes it is very, like narrowing, what she told, where Watchman is a preferred device. But if you end up using a amulet, it will become a strawberry. It will get more compressed. Visually, you feel it is safer because it's much more compressed, but the hooks are not released there, so it's not the safest position. Safest position is a tire. Now, what if there is a lobe without a neck and it bends this way, that way? You can name whatever you like, chicken wing or whatever you like, but it doesn't matter. There's a lobe which is very no without neck, like the case he had. Most toughest of the cases, which most people fail because you just don't know what to do. Only way is maybe take a pigtail, go inside that lobe, which is safe. Then, anti-clockwise your sheath, go inside, just release your lobe there, come out, release your disc. So that shortens the procedure. And in those cases, septal puncture becomes very crucial because you're maneuvering much more. Watchman is extremely tough in those cases because you don't have a place, but this is good. So in matter of time, I think there's one comment there, one here, and we'll go to the next.
Yeah. No, no. I was just thinking aloud. Maybe the software, virtual imaging software, which Dr. Devi showed, probably that could have helped us in avoiding the
Yes.
situation.
Yes.
And maybe Dr. Dagubati can say, is the software coming or entering India anytime soon?
Yeah, I mean, there are two types of softwares that we have. True Plan, which is mostly Watchman Fios is with the Amulet. Both of them will analyze this and say whether that can be compatible or not. And actually, some of these patients probably are not even taken to the table because this may be very difficult with Watchman. You may not be actually, it might be embolizing.
There is no depth here.
Yeah, okay. Absolutely.
Yeah, so I just wanted to ask, out of the three available devices in India, we understand the difference between this Boston device and the other two as far as the choosing the device is considered. But is there any point between this Emplazer device and LifeTech device, which one to choose, or they can be chosen, interchangeably?
See, Prakriya, whatever limited experience I have with both the devices, I cannot say that I have a extensive of 500 or 300 patients with both the devices, but whatever limited experience I had, I think both can be used interchangeably, except probably if you have a bilobe kind of a LA appendage where you need a differential kind of a disc, or where the landing zone is narrow and the mouth is pretty wide, and then there is another big lobe which is coming from the side. So you can put your lamprey device in one of them, and the larger disc is going to cover the entire mouth. So I think that is one thing which is really going to help us. Otherwise, more or less, you can choose both, any one of them.
Okay. Thank you, Dr. Purohit. The next, thank you very much. Yeah.
Thank you for your informative talk, Dr. Bharat. And next, we'll move to pre and post imaging for amulet device by Dr. Satish Govind.
Uh, Good morning to all of you. So you have seen some really wonderful cases, copybook and picture perfect. So my job is more like a summary and a review of what you've seen since the early part of this morning. So just a brief look as to how these devices are sort of categorized. So you have these plugs, pacifiers, and you have the ligation devices. So we are looking at the amulet, which is a pacifier device. And again, a very familiar one. So just to reinforce the different parts of it. So you have the disc over there, and then you have the waist, and then you have the lobe, and you have these stabilizing wires. So this is a little bit of a high resolution sort of a picture which shows you how the device and how it sits and how actually it manages the problem. Now, when we are looking at the pre-imaging, so the main idea is to make sure that there is no thrombus within the left atrium. So you have to rule out the presence of any left atrial thrombus and the appendage thrombus. Also, I have to look at the atrial septal abnormalities, a very large PFO with significant shunt, so we'll have to rethink, and a very large atrial septal aneurysm, again, not a good situation. So these are some few areas where you need to make sure that you don't get into any issues. And also have look at the before the procedure starts to look at the pericardial effusion. So some patients do have some sort of a baseline pericardial effusion. So keep in mind that will be the thickness over there, and then you can use that as a comparison later on. And next is to look at the shape of the ostium. So here again, it is something which the CT would have already looked at, but the 3D to some extent can help. Now, the views which we have been sort of repeatedly been looking at and showing and talking about it is again just a summary. So you have these 0, 45, 90, and 135. And 45 is called as the short axis or the minor axis. And then you have the 135, which is called as the long or the major axis. Then the views on the X-plane also can be sort of utilized. So if you have at 0 degrees, you do the X-plane, you get the 90 degrees on the opposite side. And if you go to the short axis 45 degrees, you get the 135 degrees. So you can use this to sort of shortcut your approach and sort of minimize your time, or if you don't get a good 135 degrees. So you can use the X-plane or the biplane. Now the measurement always is a bit of an issue as to what. So here again, the measurements are done in all the 4 views. And one looks at the top one, the ostial measurement, and then the circumference, the landing zone measurement. And again, the maximum diameter is taken and the minimum diameter, and you take a mean diameter also. And in echo, it is the end systole which gives you the largest dimension. And in comparison, when you look at the cardiac CT, so the echo, especially the 2D, underestimates by almost up to 3 millimeters. 3D is slightly better, but still lesser than the CT. And again, it's well known that we need to look at the volume status, and typically we would like to have a mean pressure of somewhere around more than 10 to 12. And once this is done, then the measurement, the sizing is decided. So this is again to look at the way the landing zone is going to be, that line roughly around 12 millimeters below the ostial plane. And you have the circumflex, the red arrow, which tells you where the circumflex is going to be. Now, just to look at the anatomy. So this again is a little bit of, sometimes the anatomy can be a little bit of a challenge to people not familiar with TEEs. So the pulmonary vein comes at the back, and then you have this pulmonary vein ridge, also called as a comedian ridge, also called as a Q-tip. Sometimes it can be very prominent. Then you have that ostial plane. So that again is right at the top. And then you have the landing zone. So that is within 12 millimeters. And this is where the lobe, the device sizing is done. And further down is the depth. The line goes perpendicular to the ostial plane, and it is parallel to the wall, and it should be to the length of the main lobe. And make sure that you don't go into some accessory lobe into it. Now, the watchman on the other side is slightly different, just to show a comparison. So this is more of the depth which is taken. It's taken as a maximum depth here. Now, the septal puncture. So septal puncture, again, you're going to go inferior and posterior. So this is for the superior appendage, because the left atrial appendage is supra-anterior. You need to have the right trajectory. For mid to inferior directed appendages, you go a little less inferior. And the views are bicaval. So this gives you the superior and the inferior orientation. And you go to the short axis. So this gives you the posterior and anterior orientation. And it's important that the tenting has to be established whenever you're looking at the T to guide you to get across. So the tenting tells you where you are. And the second point is that means you're still within the right atrium. So the moment you lose the tenting, that means you're across. So once the site is established, then the puncture is made. So this is just to show how, the punctures can go a little awry if one doesn't go in the right direction. So this, though it's for the Washman device, so it tells you that if you go through the anterosuperior, it goes across the appendage, and if you go more sort of inferior-posterior, you hit the appendage more likely. So the trajectory is very important. And very anterior left atrial appendages, you need to go the little posterior. So the puncture is very posterior. As you can see here, the red line, the red arrow tells you that you really have to go very, very posterior so that you get the alignment and the angle across, and then you go in. And again, on the T images on the other side, you can see that it is very posterior in the short axis here, which the white arrow shows in the short axis. Now, a very posterior left atrial appendage, the puncture is more anterior or through a PFO. So this again is suggested, so it can be sort of utilized. Now, the bicable, again, some caution here. So the thick portion is something where you never go. So that is one. And then the green portion is where the thin portion is. That's where the fossa ovalis is, and that's where you go. And in that, you go inferiorly. And on the posterior side, on the short axis side, you go posteriorly. Now, you've sort of been hearing since morning about the ball, the triangle, and then you have the tire, and then you have the complete opening of the device. So initially, you are going to sort of look at sheath retraction, and then the next two steps is more of the delivery cable being advanced, and the final step is where the sheath is again retracted. Now, on echo, so you are going to look at the short axis as far as amulet is concerned. Typically, somewhere in the short axis, it can be anywhere from around 35 to 70 degrees, depending on how the view is. So you look at the delivery sheath. So the wire which is parked in the pulmonary vein, you get to see it, and then that's a reassuring sight. And then the sheath comes in, and then you start to sort of withdraw. And then once it is off the pulmonary vein, now it is directed towards the left atrial appendage. So this sort of, it's a real time where you're looking at the fluoro as well as the T. Next is again this ball which is there. So you can combine both the viewings. And then this triangle which is now starting to happen. And then it's starting to go beyond the circumflex over there. And once it is starting to sort of fully, the delivery cable is, the sheath is retracted over there, then it starts to become the tire over there. So this is again tire shaped. So each of them have their own shapes over there. Then finally the cable is withdrawn, and then you have the device in place, and then you're starting to look at the settling of the device, and then you can see the concavity over there, and then it is away from the mitral valve, and then again, as was pointed out in the morning, it should be sort of above the ridge over there. So that means it's a nice and easy sort of sitting, and then it is stable over there. Then you do this tension test or the tuck test, and then you make sure that the device is stable, and also put on the color over there. And in color, it's ideal, better that because these leaks are low velocity flows, it is better to sort of bring the velocity scale somewhere at around 30 to 40 so that you get to see the low velocity flows better, and then the peri-device leaks tend to appear a little better. So they are better seen with the 2D itself. And then again, this is the final wrap up where you start to see the mitral valve, and then you sort of look at it from all the views, and make sure that the pericardial effusion, if it is there, or a thrombus formation. And also lastly, before, very unlikely, but it's more like, making sure that you sort of, what is the status of the iatrogenic ASD which has been left behind. And then one can look at the device over there. So typically it is called as a figure of 8. And this again on first 3D, which provides you the information, and you can look at it from different views, and you can put on the color. So color again, you can have to reduce the scale so that you get to see it. So the location of the on first view tells you where the peri-device leak occurs. So you're combining both the 2D as well as the 3D to come to a conclusion. So in sort of, coming to my last few slides, so this is if there is a peri-device leak, so you have this mechanism where these leaks happen. So it can be between the disc and the lobe, or it can be into the leak into the distal atrial appendage, and then you have the uncovered area, and then you have a fabric leak. And then you have this algorithm where you go through this and you look at any additional sort of steps where you would like to look at to close that peri-device leak. So this is sort of in summary as to how to sort of go about it. So one is to look at the size, lobularity, and the shape, and then to guide the device selection. So to guide transseptal puncture, and then the position of the delivery sheath, and then the guide the delivery deployment, looking at the position, correct orientation, check for leaks, and any other complications. So that would be the role of T. Thank you.
Fantastic pictures and imaging. We were just commenting about that, how great these images are. And, with the proper imaging, the interventional cardiologist or structural interventional cardiologist time is reduced to maybe like doing the procedures only for us 10 minutes. If somebody like Dr. Govind is there, your life is easy. So call him for all your left atrial appendage closures, wherever you're doing it. thank, thank you.
Yeah. And I can vouch for it by personal experience. Yes, he made for me, and it's fantastic. Very good imaging. Any particular anatomy you're scared when your intervention does this procedure, in appendage? The complex anatomy is a problem because you don't get to choose. You are just thinking that it is simple, but there will be some cases which are complex. So any particular
Yeah, one is a technical issue. So when we look at transthoracic, we talk about windows. So I would say that even T has got its windows. So sometimes, you don't get the right window in the right angle. So that is one which always, once the probe goes in, you're always looking to find out whether you get a good window. That's number one. And secondly, you have these really shallow sort of low, the tights, which those are the challenging ones. And sometimes I don't know, so sort of what's happening. So those are, the two situations I would say.
Just basic question I'll ask you, because we have for those centers where they are doing the LA appendix occluder initially, we have seen that the proctor comes, but the guy who is doing the TE, he struggles to find a good window when it comes to septal puncture. The needle is coming, and we are not seeing whether it is coming truly in the bicaval view or in the AP view. So any tips and tricks you can give to the guy who is then doing TE, maybe relatively not very experienced, but still he is able to do it. But is there any tips and tricks which you can share so that they can get a better window?
I think I would compare it with something like a puncture. So the more punctures you do, the more familiar you become. So the more T's you do, the more familiar you become. That's number one. So the familiarity of the procedure itself. And secondly, of course, is even among the T's, you have good probes. So this is a high-end probe which I use. So you get some really good images. And third is that you sort of need to the septal puncture itself is a learning curve. So for me also, it took quite a little bit of time to repeatedly sort of get exposed. So it takes a little bit of time. But now I would say that if you sort of get a good focus on I think the aim is to get the good bicaval and a good short axis. I think even if somebody who's not doing a T, but his guide who's supporting a procedure, I think the bicaval and the short axis and the fourth chamber, I think the three areas where they should look at it. And whenever they do a T for some other reason, I think they should spend a little time and getting a little familiar with those views.
Yeah, thank you, Dr. Govind. And we are also having a T simulator, which is next to the Hall B, and the courses are being conducted right now by Dr. Satish Govind and Dr. Kavya. So anybody interested in batch of 5 can go, and it's an amazing simulator where you get experience on how to image all and different anatomy. All different anatomies can be seen there. So I would request you all to make best of this opportunity. And Dr. Ramesh is already fixed one more schedule for the next conference. There is going to be a bigger schedule by Dr. Satish Govind on how to do a proper imaging. Thank you, Dr.
Thank you.
So is Dr. Devi Nair ready? Yeah, it's ready. Okay. Dr. Devi, can you hear us now? Yeah.
Okay.
Yeah. Dr. Ramesh. Yeah.
Yeah, Devi, fantastic for you to stay till 11:30 at your time, but management of a peri-device leak is a very important topic, and we know that actually it is associated with outcomes, and we're waiting to hear from you. Thank you.
Thank you. I'm going to go ahead and share this. Can you see my slides?
Yes, we can. Yeah, thank you.
All right. Thank you. So for this session, I'd like to talk a little bit about leaks. And I will say that leaks have emerged as a whole new field for us in the last many years as we started to learn more and more about appendage closure and what that means. These are my disclosures again. So the question is, why do leaks occur? What happens, you saw the imaging, and when you have impeccable imaging, that's when we see that you're trying to put these circular devices in non-circular orifices. Like most of the appendages are oval or foot-like, teardrop. I mean, it's about 20 to 30% appendages that will actually have a round opening. And sometimes it's because of incomplete coverage of orifice or lobes. You can have undersizing of the device. You could, have an off-axis orientation or malposition, like what initially happened in one of the cases. And sometimes it's just the patient and then protoplasm and just incomplete endovascularization, and that's a hard one. Uh, Now, sometimes for certain devices like the lariat, you can sometimes have a migration of the device, even with one of the newer challenges we see with the Watchman Flex device is the distal migration of the Watchman Flex device. And then the concept of remodeling of the left atrial appendage after you close it is also being quite entertained. And this was, I think, a great paper on peri-device leaks by Dr. Al-Khuli. And Mohammed did a great job of putting in some of the reasons. This is just some of the mechanisms of why leaks come with blood occluders. You can see it can be an edge leak, or uncovered lobe, could be proximal tissue that is uncovered, or it could be just a fabric leak where things are not proposed and it goes through the fabric. And the mechanism is very different for a lobe and disc occluder. You can see it can be a leak between the disc and the lobe, which is very different than when you actually have leak into the distal LAA. This is more of an issue. Or you can have uncovered proximal tissue. Say your disc kind of goes under the committed ridge, or it can be fabric leak, just like the plug devices. Now, what are the theoretical effects of incomplete closure? The idea is that you have this open pouch with residual flow into the appendage that creates this turbulent flow, and it could enhance platelet adhesion and thrombus formation. And now you have a connection to the stagnant blood flow that allows for the thrombus to accumulate and embolize into the systemic circulation. And this is generally the concept that we are dealing with. Now, the question is, how frequent are leaks? Now, this is again a meta-analysis by Cooley and his team that looked at what the incidence is of peri-device leaks at 45-day follow-up. You can see it's wide variation. If you go in the evolution trial, being the average the smallest rate of about 8%, all the way up to the Watchman 2.5 of the AMULET IDE trial, getting up to about 55%. So a wide range of leak rates that we see. This is early data from Protect and Prevail, from Evolution, from the ACP AMULET experience. You can see at the 12-month, we were looking at about 32% in the Protect trial, 12% in the ACP trial. This is more recent data from the AMULET ID trial. Now, what you're seeing here is, the definition of leak changed quite a bit over the time. We always used to say this arbitrary number of 5 millimeters as what's considered to be significant or non-significant. And if you ask, people like Dr. Holmes, David Holmes, or Saibal Kar, or Dr. Seward about, where the 5 came from, everyone has a different answer. And it was just one of those numbers that Dr. Holmes came up with is what I hear every time. So the whole idea of this, if it's under 5 millimeters, is okay. It's something we're not entertaining anymore. We like to do things with no leak if at all possible. And then now in the AMULET ID trial, you'll see they actually started looking at 0 to 3 millimeters, 3 to 5 millimeters, and then over 5 millimeters. And again, you'll see there was quite a bit of difference between the AMULET arm and the Watchman arm. Now, if you looked at just less than 5 millimeters, that was not as much of a difference. But if you looked at less than 3 millimeters, there was quite a significant difference between the Watchman and AMOLED arm, making the AMOLED actually be classified as most superior when it comes to occlusion and leak rates at 45 days. And that kind of stayed on. They looked at the same PDL severity at 12 months as well. That difference kind of stayed, and the durability of the closure kind of stayed. This is data from the Pinnacle Flex trial that looked at Watchman Flex data. You can see the 12-month leak rate was about 10%. And now that's much better than what it used to be. It was about 44% in the Protect trial. So definitely sort of 33% in the Protect trial, which is much better than what it used to be. But still, again, we have a long ways to go. Now, what are the kind of predictors for leak? Now, one of the biggest things is the type of AFib, or if it's long-standing persistent AFib or permanent AM, especially with increased left atrial size, the left atrial appendage size, the more elliptical the left atrial appendage, high, left atrial pressures being high, and moderate to severe MR, which the concern is that it might not allow for endothelialization of the device, especially if the jet is directed towards the appendage closure device. Now, some of the other predictors that we see, especially the AMOLED device that's been listed, is again permanent AF. Device position is a key factor for the AMOLED device, also for the Watchman device. Now, I'll put that way. It doesn't matter which device, but definitely the orientation of the device. If the device lobe is off axis or the lobe is too compressed, you do run into the risk of leaks with these devices. Now, how do you assess it? There are quite a bit of limitations. This whole idea of 2 millimeters, 5 millimeters, or 3 millimeters, it all depends upon what part of the leak you measure. So most of the leaks are just not a circular thing. It's usually a crescent. And so if your imaging plane falls through different parts of that crescent, you're going to pick up 2 millimeters or 3 millimeters or 5 millimeters in that same leak. And so it's very important to make sure that you are getting a pretty good assessment of a three-dimensional assessment of what that leak is. And avoid some of the other reasons that could cause overestimation. Now, CT continues to evolve as one of the more sensitive imaging tools that allows us to, quantify leaks. Now, when they looked at some of the data on TE leaks, there was 100% sensitivity when they looked at cardiac CT. Every leak on TE was picked up by the CT, but if you looked at leaks, they're in about 100 patients, they looked at CT versus TE. There was leak noted in or contrast within the appendage noted in about 51% of patients on CT, and only 34% of those patients on TE showed the leak. So there's this concern that CT seems to pick up leaks or contrast with appendage much better. Now, regarding the AMOLED device, CT helps classify that leak a little bit better as well, to grade 1 through grade 3, depending on where that leak is. Grade 3 being the worst one, where you have leak around the lobe and contrast into the distal left atrial appendage. So leak past the disc, past the lobe, into the appendage, which is clean, which is what we definitely try to avoid. But definitely we are seeing more and more data that the CT imaging is probably more sensitive in picking up leak and also quantifying the type of leak. What we're seeing is that on CT, when we quantify, the CT seems to show the leak rates, the leak size to be at least 1.9 millimeters on an average, bigger than what TE estimated. And that could make, sometimes make or break the decision of what you're going to do with that leak. So again, it's important to have multi-faceted imaging for these things. Now, why do we care about leak? Like Dr. Everybody said, more recently we've seen that leaks matter. We see that device leaks at 1 year are associated with higher ischemic stroke rates. This is meta-analysis from the Protected Prevail data. This is looking at the NCDR LAO registry. This is all the patients that have Medicare insurance that get an appendage closure in the U.S. Their data gets entered into this registry, and you can see that saw even small leaks that are associated with a modest increase in composite endpoint of stroke and systemic embolism at 1 year follow-up. So we know that leaks matter. We saw that again in the AMOLED IDE trial. This is data up to 18 months from the AMOLED IDE trial, with significant increase in stroke and systemic embolism in patients who had leaks in both the arms, both AMOLED arm and the Watchman arm, even though the leak rate was much higher in the Watchman arm. And that was the Watchman 2.5 device. We also saw in the pooled analysis by Dr. Vivek Reddy and his team that the rates of ischemic strokes were significantly higher at 1 year when the leaks persisted. This is a meta-analysis again by Kuli and his team that looked at the different trials, and you can see those ischemic stroke rates vary anywhere from 2 to 9 to 10%. And so again, those are pretty large numbers in a patient that we committed to appendage closure. So the question is, how often do you image? There is a concern that there's temporal changes in leak and that you can have delayed peritoneal device leak where you do the appendage closure. You know, nobody wants to leave a leak behind. You're trying to do the implant. You want to be appropriate, adequate, and optimal implant, and you think you have not left a leak behind, and then at 6 weeks now you image it, you see this leak, and there's this concern that as LAA remodels, you could that leak could get bigger. So the question is, how often do you image? And in our institution, we tend to image at implant and then at usually at 3 months. And if we don't see a leak in 3 months, and we usually do CT imaging in 3 months, if we don't see any contrast into the appendage at 3 months, we usually do another imaging at 1 year. Now, if we see any contrast extravasation into the appendage, the question sometimes then is it coming through the fabric or is it a device? And depending on that, we will re-image at 6 months or 12 months based on what we've seen. The question about how do you manage it if you find, there's really no universally agreed upon definition of what is considered to be relevant size of the leak. And, you know, obviously the leak over 5 millimeters was considered to be relevant for attack. You know, we now advocate for a much tighter threshold. You know, 3 millimeters or higher is at least something that we really worry about, at least in our institution, especially a leak that's from a large uncovered proximal lobe is a different concept by itself. And a leak that has now caused a thromboembolic event is now, you know, it's a different level. So these are some of the leaks that we will take into consideration most seriously. And how do you close it? I mean, there's multiple ways. I mean, this is just, again, in my mind, it's just something we're still learning what's the best way. There's really no specific tools designed for it. You get real creative with these things. You can have another LAO device. You can have coils. You can have plugs. Now, sometimes I'll show you some cases where we do coils and plugs together. Or sometimes we'll do radiofrequency catheter ablation, especially if it's like a narrow leak and we're trying to increase fibrosis and increase edema and fibroblast recrusion. So there are many ways of doing it. And if you look at some of the data, there's really no published data other than case reports and stuff. About 42% of the leaks are closed with foils, about 30% with plugs, and about 28% with as a second appendage occluder device. And this is looking at small leaks. And again, these are all case reports. They're not like meta-analysis. So you can see most of them are closed with foils or plugs. If you go to a medium leak, you're again seeing foils and plugs in those cases. And for the larger leaks, you're seeing a second device, an actual bigger device being used. And that just seems more reasonable. So in our mind, the way we look at it, you know, if it's a large PDL that's over 10 or anything that's moderate, 5 to 9, you know, usually we end up using another closure device or sometimes a foil and a plug. And then this is kind of that gray zone where we don't know what to do between 3 and 5. So usually if the patient has any kind of thromboembolic event or depending on what the CT shows, you know, we'll have that discussion with the patient. We actually put them on half-dose oral anticoagulation or we recommend the closure in this patient. And the small leaks, we kind of follow and manage. So I would like to go through some cases of some of the leak closures. Some of these span from a couple of years ago to more recent stuff that we've done. This is some of the early cases where we just used to do coil. You can clearly see this is a legacy Watchman device with the leak along the posterior wall. You can see the coils, these are terminal coils that we're just kind of putting in through an empty catheter into that leak. And the idea is that once you put that coil in, that it creates a thrombotic environment and just thrombosis that off. And you can see, I mean, these are not pretty pictures because coil just makes it ugly. And then once you have coil, it's very hard to image with CT as well because it's just so, I guess, imaging gets really, you get blue artifacts and things of that sort. So now this is an example of, you can see this is again another leak here in the bottom here. You can see, you can look at the angio, clearly see that leak with contrast going past the appendage closure device. This is again a Watchman device. And again, these pictures are never pretty. This is filled up with walls. One of our older cases where we did it under ice guidance in a patient that had a pretty large leak. The idea is if you're going to do coil, you got to fill up the whole space with the coils. Now we do more of plug along with the coil to avoid the coil migration, etc. So this is a case where we're using a plug. You can see on 3D what that leak looks like. You want to size your plug to cover up that entire three-dimensional space to make sure that you are doing a good enough job of covering that entire three-dimensional space of what that looks like. You can see the little plug kind of covering that leak in its three dimensions. This is an example of a case where you can see there's a pretty large leak along the mitral side of that watchman device with chicken wing anatomy. This is an off-axis implant for sure. Here you can see we're putting in a PFO occluder device because we needed a bigger device and a better seal. So here you can see this is a PFO closure device. And once we put that PFO closure device, you can see there's a small leak at the top as well. So we decided to do an ADO occluder and hydrocoils in there. So here you can see we put some hydrocoils in there and then went ahead and put the ADO occluder device right there. So it's something you can clearly see the two plugs is the PFO closure device and the ADO occluder device with the coils in there. So it's a I guess I don't know, multiple devices like that. This is probably the most easiest leak to close as a post-lariat leak because it's usually just through the center. It's usually a single hole there, and you can just kind of put an ADO closure device through it. It's truly the most easiest leak to close. I would say that most leaks are not the easiest things to close. They require quite a bit of work and manipulation. This is an example of a posterior lobe that was missed. This was one of our early cases. And you can see that there's an ECP device that's gone into that lobe. Again, remember, some of these devices have fabric, some don't have fabric, so you have to remember what kind of anticoagulation you use after that based on the type of fabric or type of device that you use. So in this case, we used two devices, this ACP device with the whole watchman device. This is an example where you have a watchman device with a very narrow neck of the lead. And in that case, this patient actually came for a redo ablation for the AFib, and we actually used the RF catheter. You can see the RF catheter going past the leak, and we just ablated all the way along that leak. And the idea is that, yes, you will see acutely, you'll see the leak kind of close because you get edema and whatnot. But the idea is not just the closure from the edema, but the idea is that to actually recruit fibroblasts and increase scarring and hopefully improve endothelialization and whatnot. And it's not my favorite thing to do, but sometimes, especially if it's a very narrow leak, then I'll do it, especially if I'm in there for an aspiration. This is an example of a missed lobe. You can clearly see the watchman device is sitting just in the anterior lobe. This comes down to having good imaging at the time of implant. If your imager was not able to show you that posterior lobe, you did not have a good angio, you will easily miss that posterior lobe. And here we're actually using a deflectable amylin sheath to actually get access into that posterior lobe. This is almost treated like a chicken wing anatomy with the sandwich approach, where we kind of chunk that lobe back into that posterior lobe and then put the disc to sit over the watchman device so you have overlap and coverage. So that's using another one. This is an example with a different sheath called the Vijayawada sheath. The Vijayawada sheath is different in the sense that it flexes in multiple planes. So each of these, it looks like the pens that you have these multiple color pens when you pull down and you get a different color. So same way, it's that concept where you can pull down and you can have that sheath go in multiple different directions. And this is an example where there's a complex leak that could not be closed initially because we couldn't get access into it, and we brought in with the Vijayawada sheath and got it with the talisman device, which is a closure device. And you can see we went past and went through it and closed it. Again, this all depends on what access points. And this is where it gets challenging, especially if you are trying to find. This is again an example of a post-surgical ligation. This was a patient that had LA ligation, and you can see they left, the ligation did not take it, and you have a pretty big leak. Usually those you can close with an LA closure device. This is the amylin device that clearly closed off the leak. Again, it depends on what type of LA closure that you're trying to close. This is a very interesting case where we had a patient that actually came in, had this as their appendage to begin with. This patient had multivalvular surgery, and they put a clip, and you can clearly see on the CT the clip is just at the tip. We call it tipping of, clipping of the tip. You can clearly see the entire appendage is still kind of open. And this patient actually was seen by one of our neighboring hospitals, and they put a Watchman device in there. And you can see when the patient came back for CT imaging and the rendering, there's definitely leak through there. It's a very tilted device, and there's leak through there. And so when we look at the CT rendering, that's what it looks like. Now you actually have a clip and a Watchman, and you have a leak along both sides. So this was probably one of the most complex ones that we've done recently. You can see this was a Watchman Flex device, and you can see the leak on the top, the leak on the bottom. What we did is, you saw on the CT that the struts were open, so we actually went with the talisman device through it, and we used the Watchman as the anchor and put the lobe inside the Watchman, so the Watchman was holding onto the lobe, and then using the disc of the ASD closure device as the occlusion. This is a case where the Watchman Flex device, which is one of the challenges with the Flex device, is that you can migrate more distally and get off axis. So you can clearly see how it's off axis. And I mean, you can put closure plugs in there, but the device is so tilted that the leak is so off shape that you won't be able to fix it with just a plug. And so what we did is we punctured the fabric of the Watchman device. And this is that VersaCross wire. So we actually use radio frequency energy, and we punctured through the fabric of the Watchman device and get past the Watchman device. And again, the concept is to use the Watchman device as the anchor. So here we're putting in, you can either put an amulet device or a talisman device, depending on what sizing you need. And here you can see us coming in with the lobe of that device, and that lobe is actually inside the Watchman, and the Watchman holds on to the lobe. And then as you're putting that disc out, you watch, because this Watchman's been inverted with, so it's pretty endothelialized, it's just off axis. So you utilize that Watchman in your favor, and this is what it ends up being. You have the lobe of the amulet device inside the Watchman, and the disc now covering the orifice of the Watchman. So this is one of the things. So to conclude, I think the best strategy obviously is to avoid the leaks, to take your time in planting properly, and to optimize the device placement, whether you do imaging tools or whatnot. It is important to remember that leaks matter, whether if it's small, I think watchful waiting and repeating imaging is fine. But if it's moderate or large leaks, I think the appropriate closure strategy or anticoagulation is. Thank you very much.
Okay.
Very informative talk, Dr. Devi Nair. I was thinking, I think everybody in the room wanted to go back and start LAA, but with this talk, I think they're scared now to start the program.
No, I think they're amazed at how agile you were with your hands and in closing these PDLs, and actually are able to get all the best results for these patients. I know, congratulations. I think there's one comment from our audience here.
I want to just take a minute to kind of.
Yeah, sure. Yeah, sure.
Obviously, the cases that I'm showing are like some of the better cases. Leak closure is one of the most challenging things to do in my mind, because there's no particular device you can use. You have to get creative with it. There is risk. There's quite a bit of risk associated with leak closure, because now you're going into uncharted territory. So I think it's very important as you decide whether you're going to do leak closure to assess what that risk-benefit ratio is. It's very different risk, I think, that just as first-time appendage closure. I think the best thing obviously is to avoid it, and maybe think it through before you do it.
Yes.
This is Dr. Srinivas. I have a couple of questions, madam. One is, what is the timing of second intervention after the first device is in? When do you want to re-intervene if you want to do a second device? That's the first question. Second is, as you have rightly said, there is no data on what is a significant leak. So is there any data on the patient outcomes between a 3 millimeter residual leak versus 5 millimeter residual leak? Because this 5 has been for quite some time now. Do you have any data on that? Thank you.
So I'll start with the data question. There's definitely now data that the leaks that are over 3 millimeters are associated with higher risk of TIA, systemic There's quite a bit of data from Dr. Natali and Dr. Fortune's group from Austin, where they've shown that association of stroke in these leak patients, especially as you follow them over time. Now, regarding whether leak closure helps with stroke reduction, that data is currently being analyzed. I mean, there's a registry that's ongoing that all of us are participating as we do these leak closures. We're trying to collect that data to show, best practices, outcomes. We don't have that data from that standpoint, but we definitely have data now that shows that leaks matter, and moderate and large size leaks definitely matter. The small leaks need to be watched.
Yeah, one more question, sir.
One comment and then a question. It is surprising, even interesting. Such a small leaks hold on large ASD devices. That is one. Surprising that so much space is there. The question is there a comparison of patients without appendage closure having stroke risk versus PDL patients having, in other words, does PDL de novo exposes the patient to a initial original risk?
That's a great question, because I think it comes down to the whole concept of do no harm, right? So there is definite data that the stroke rates with the device leaks are much lower than if you had a patient that had a bleeding risk, and you decided to just discontinue their oral anticoagulation in a patient that had a CHA2DS2-VASc score of 4. That patient's stroke risk when you discontinue oral anticoagulation is definitely much higher than if they had a peri-device leak with the appendage closure. So yes, it does increase your stroke rate if you do have a leak, but that stroke rate is still much lower than if you did not intervene. So yes, I mean, that's always been a question, and that's similar not just for leaks, but it's also the same for device-related traumas, because it keeps coming back. Are we causing harm by putting these devices in? And the data clearly shows that if you actually, the stroke rates in the setting of peri-device leaks and DRT, we're looking at a small magnified population. That rate is still much lower than if you did not intervene.
Okay, thank you.
You asked me about the large leak closure devices. You're right. I mean, it depends on what type of leak, and it's not that the neck of the leak might be small. And if you think of it, the beauty of ASD closure devices is they have a neck in between. So if it all depends upon what can you put distally. And in that last case that I showed where there was no room and there's quite a bit of leak, you have to I had to use the inside of the watchman as the place to put the load, because there's no place to put it. So that's why I said you get real creative with these things to make it happen. Now, most of the time, what you'll see is people using just ADO devices. The problem with ADO devices is, sometimes they're not that stable, and they don't have a fabric on them. Then you're exposing the patient to anticoagulation again. So, and they're sometimes too small to cover some of these large leaks, and they don't have anchors. And that is something you have to still keep in mind. The ASD closure devices, the ADO device, the plugs, they don't have anchors to hold anything on. So you have to make sure that they are holding on to something. Either they have to be behind the device that's already there, or inside the device. So those are things that you have to keep.
Thank you.
The second part of my question, what is the timing for the second intervention if you want to do?
Oh yeah, I forgot, sorry. So I try I try to give at least 6 months before I go back. So if I do a CT, or if I get referred at 3 months for a leak, I usually will wait. And during that time, I put them on a half dose oral anticoagulant, usually at Eliquis 2.5 BID or something like that. And I leave them on that half dose until 6 months, and I re-image them at 6 months. At 6 months, depending on the size of the leak, is when I will intervene. If it's getting smaller, I don't mind waiting till a year. But usually before 6 months, I don't intervene. And it's rare if you keep them on half dose OAC, then you don't really run the risk of stroke and systemic embolism is very small. And Dr. Natali and his group has shown that half dose works in this group.
So Devi, one last question from me is that what are the predictors of non-coaxiality of the watchman?
It's a, okay, so it's a, for Watchmen and don't call it, well, it starts with the transeptal. So if you start off with the off-axis transeptal, you know, you have, say, if you have a posterior mid-spine and you come with your regular transeptal, which is inferior mid location, then you could have an off-axis device because the device is going to be tilted out and the appendage is tilted down. You know, so something of that sort, where if your transeptal is off-axis to begin with. The second thing that changed, the more recent issue that we've started to see with Watchman Flex device is that because the distal end of the device is rounded, you know, yes, it is a safety feature of that device, but it also allows for that device to move distally. So it allows for distal migration of the device more than proximal migration. The distal migration is an issue. So more recently, as we are using, say, when we use a Watchman Flex device, we try to not just size it according to the orifice, we try to fill the entire appendage with the device. So the device has no room to move distally. So if you have a device that's a, say a 30, say the orifice is asking for a 31 millimeter, but you have depth for over 35 millimeters, we'll actually put a 35 in there so that the entire appendage is filled with the device so that it doesn't move distally, because that device tends to move more distally. And that creates this whole, like, you know, especially if your device is past the 10 millimeter from the circumflex, you create this big area that it becomes a nidus for problems. So those are really the main things. I will say that, you know, we have the steerable sheet for Watchman now. So we have the steerable sheet for AMOLED as well. But that has actually reduced some of that off-axis implant of the Watchman with the steerable sheet. The steerable sheet obviously is a 19th inch over D, so a much larger sheet, but definitely adds some value to that. But mainly it's the tilting of the device and making, you know, just because the device just tries to, you know, suck itself in.
Thank you, Dr. David. It was a wonderful talk. I'm sure you know, we learned a lot from you. Hoping to have you in person next year whenever we do the conference. Thank you. Okay. Big round of applause for that. Yeah. So, yeah, quick announcement. We are starting a cardio metabolic symposium in Hall B. The speakers are already there. Uh, Anybody interested, please join in Hall B. The next talk is by Dr.
LC guided LAA closure by Dr. Ramesh Gadubati.
Yes.
Okay. Yeah. So good morning. I think it's really fantastic to see so many people on Saturday morning as well here. So let's talk about the need for ICE-guided left atrial appendage occluder. No, that's okay. Yeah, as long as it's okay. So why do we need ICE versus TE guided? So it all depends upon where you are and how good of a center you have in terms of patient's throughput. So I was just telling Dr. Ranjan Shetty earlier that the reason that I switched to ICE was I was not one of the people in my role is also I need to look at the cost of every procedure that we do in the hospital. Cost control is my pet peeve. I'm very cheap and I try to save money for patients, for everybody, insurance payers as well as taxpayers and the hospital. So when we looked at it, the ICE is always going to be slightly more expensive. And we can easily do 4 or 5 left atrial appendage occluders with the TE guidance, with anesthesia in one room. Okay. So then I didn't see any need for that. One of my patient, while waiting for a procedure, I mean, obviously, if you want any type of imaging this is pre-COVID, we used to get a TEE or a CT scan, and that is a routine. While waiting for that and has to wait to get that imaging, has to wait to be seen by an anesthesia nurse practitioner, so pre-anesthesia checkup, and then she has to be scheduled. So this took almost 5 weeks. In the meantime, she had a massive stroke and died after some time. So then I'm like, okay, so you know, every time when you listen to anybody's lecture or topic, think about it. Start thinking outside the box. Just because 99 people going this way doesn't mean that that's the right path. You always have to think about why do we need to do ICE? Why, you know, so no, not many centers do ICE in US as well. Everybody thinks that the same thing. You know, imaging is very easy and very good. So for me, that was the reason. So I can't get a patient through my hospital faster than probably the other hospitals in India or other hospitals in the United States. So that was the reason that I said, okay, let's look at the ICE again. And the bottom line is ICE equals TE. That's not the debate. The debate is not like, okay, it's actually for my own personal life, TE is best. I don't have to be in the room. The anesthesia will take their own sweet time to get the patient under general anesthesia. They'll put the TE probe down, or the echocardiographer will come and put the TE probe, and finally the nurse will text me, "We are ready for you." So my fellow would have gotten a venous access, and then we are proceeding just with one venous access. So ICE is probably sometimes better than TE, and sometimes not. So the other one was issue was another patient who our scissor training institution, while putting a TE, and a patient actually had a esophageal perforation from the TE because they were training their fellows as well. So those are the two things that I said, okay, TE is not actually obviously not as safe as we always think. So the most important thing is, however you do it, you have to get the best imaging for us to implant these devices and be safe. So you need to make sure that they're coaxial, they're exactly the size and meeting the pass criteria for Watchman devices and meeting the close criteria for amulet type of devices. So I told you why ICE-guided left atrial appendage. It can be done very safely with moderate sedation. Right now, our patients come in without any imaging. I don't do any CT, any TE. If I see the patient, and as long as their insurance is approved, if I see the patient on a Wednesday in the clinic, I can schedule them on a Thursday or a Friday. So to avoid any complications, and as I said, esophageal perforations, and convenience is the most important thing for the patient. So if a patient is tolerant to oral anticoagulation, you can wait. If somebody is intolerant to oral anticoagulation, they're not on any anticoagulation, just letting them be without any protection for several weeks. Once you see, if you did not see the patient, the ball is not in your court. But once you made a decision that I'm going to proceed with left atrial appendage, I feel that I'm compelled to do something much faster than before, than other patients. So efficiency and cost. I said that, I told you already. We looked at the cost. We spend about maybe about $1,000 more with the ICE-guided left atrial appendage. It's getting the cost in the United States is like very difficult. Nobody will tell you exactly what the cost is. The hospital charges a lot more, and they have negotiations with the insurance companies. So we charge, like, for example, $40,000 for a left atrial appendage occluder. They'll pay only $20,000. So we don't know what is the cost, but we can get it through financial committees and all that. So better imaging, and we'll look at it. So the success rate of TE is fantastic. There's only 1.9% unsuccessful probe insertion. So you can use micro TEs or pediatric TEs in those patients, and you can get away as well. And if the patient has esophageal structure, and we don't do ICE-guided mitral clip yet. So some people of these with esophageal structure, we send the patient to thoracic surgeon. They'll do esophageal dilations, and they'll bring the patient back. So that's not a stroke risk for those patients. And so mitral clip patients can wait for a little longer. So, due to less than 1% are discontinued due to hypoxemia, arrhythmias, trauma, bleeding. One time, actually, the anesthesiologist came and told me, "Ramesh, can you please tell your echocardiographer to remove the TE probe because the heart rate is 40s." I was done with the procedure, and I was just walking in the control room doing my note or something, and the echocardiographer is still educating the other fellow, and so the patient became bradycardic. So it can actually, it can cause vagal maneuvers and cause bradycardia as well. Very rarely complications, that's really bad. Esophageal perforation is really bad if it happens. So in our own, obviously, major complications defined below is like 3.6%, which predominantly, as I said, that it is in much lower than usual, that number. But as you can see that in 3,000 patients with left atrial appendage occluders, death rate is 0.13%, cardiac arrest is 1.1%, and major complications all included, including bleeding and all of that, is probably 8.6%. So that's high. So even if so this includes even some spitting of blood is considered as complication in these patients. So because they're on, so the basics with intracardiac echo, what we do is first rule out thrombus. Actually, Most of the time, you can easily look from right atrium, and actually at around that 5 to 6 o'clock, you will the left atrium appendage will come into picture, and you can easily rule out thrombus in that way. And then transseptal puncture is very simple here as well. You can clearly see the tenting. And one of the things I think earlier we were talking about, when you try to, why does actually inferior become superior after some time? When we try to do a puncture, we're pushing the needle. Along with the needle, the sheath also can creep up a little bit. So to avoid that creeping of the sheath and be precise. And as I mentioned yesterday, when you have a doubt, it is not going in, use a coronary wire, it'll go easily, and advance the needle over the coronary wire. It's much more like a balanced and protected way of puncturing it without moving the sheath up on the septum and the fossa. So these are the obviously few angles that we need. If you're on the mid atrium, 90 degrees, and the pulmonary vein, if you're in the pulmonary vein, you can get the 45 degree, and in the mitral valve, 135. So that is 2D ICE, about $2,700. 3D ICE costs about $3,500. And Philips 3D ICE is what we have. We can just put it in the mid left atrium, and so then it'll actually give you both the views, 45 and 135. So those two angles are more than enough for us. And so here, this is how it'll give you the angles. And those two angles are, sorry, 90 and 135, these two angles will be more than enough for us. But if you want, you can go and do another one in pulmonary veins. And so for ICE-guided left atrial appendage occluder, you need to have two views of at least documented in sizing as well as in the compression as well. So that's how we do it, okay? So 3D ICE and MPR has definitely made it much better for us. And you can do any angles in that, but at least two angles, as I mentioned, and you can look at the 3D imaging as well. And MPR, this is how you can implant them on the right side is enough for you to do a procedure without moving too much. So why is 3D ICE? Why do I use 3D ICE? Because I have only two hands, and so once we fix that, that'll remain in place. I don't have to rotate it. It doesn't have to be any, so once it's in place, it's in place. It's anchored by itself. And so you can lock it and you keep it like that, and that'll sell usually. So very rarely we have to change. So, but still, actually, because it's expensive, we don't use it that often. We still can use it, okay? So it's, looking at 3D and TEE here, as you can see the pictures and very clearly given. I think, obviously, the most important thing is, you need to measure the sizing and making sure it's very clear. So I don't think, any difference actually, you can say that there is any difference between these two, right? And 135-degree angles as well. So next, I think we talked a lot about imaging. Again, the same thing. In the United States, probably we overdo a lot of CT imaging for every patient. Doesn't matter. I was just telling Dr. Ranjan, if a patient walks into the emergency room, says chest pain and shortness of breath, patient will get a CT pulmonary angiogram. Not even consulting anybody. That is the protocol that the emergency rooms have, because mortality is high with PE, so they want to make sure lawsuits are avoided. So lots of contrast is being given, and I think that actually, if we look at probably the trends, chronic kidney disease is on the rise because of what we are doing with contrast. So I don't actually do CT planning at all in my patients, pre or post. If there is a doubt, only so certain number of patients, if I have a doubt, then I'll do a CT. So most of the time I don't, and as you heard from my other partners do it as well, similar to Dr. Devi Nair, about 70% of them will get CT planning. And so this is something that is depending upon your things. I think Dr. Rao asked earlier, how do you, what about planning? So these are beautiful things to look at actually and tell you, and this is good, and it'll give you actually a precise puncture and very good trajectory and everything very controlled. And so it'll tell you exactly, but it is only good if it can overlay on your fluoro. If it does not have fusion technology, what is the point on telling as I told you yesterday, my imaging person will tell me, Ramesh, this is where you need to puncture. Yeah, I can see it on fluoro, right? I scratched my head, because you can't see that on fluoro. Where is the CT? So on looking at one screen on this side and thinking that on this side it is the same place is not going to be really good. If you can fuse the images, and that actually is going to be very helpful. So this is how you can fuse the images, and then actually a true plan can tell you, and actually you can say that this is different ones, and so that actually will help you where to stick your transeptal puncture. So in 197 patients randomized to CT versus standard planning, it was very helpful. So in this study with left atrial appendage occlusion with ICE versus TE in AMULET, and TE was done in 107 patients. There's no difference between any of the complications or as you heard about peri-device leak more than 3 millimeters and procedural success. All of them was very similar. So both of them match to each other, and no difference in even less than 3 millimeter leak or tamponade as well. So in AMULET, actually, it has been shown that TE versus ICE actually does not make any difference. The procedural time is slightly higher with intracardiac echo as compared with TEE. As I said, TE reduces actually our procedural time much lower. And in that registry of SURPASS registry of NCDR, which is a National Cardiovascular Data Registry, and it's a Watchman Flex patients implanted at 698 sites. 2,272 patients are ICE guided, and about 31,000 are TE guided. So relatively, less number of ICE centers that are there. And moderate or minimal sedation is used in 38% of the patients, and procedural time was 81.9 minutes, so about roughly about 5 minutes more with the intracardiac echo. So, but efficacy and everything else looks the same, and safety is slightly, composite major adverse events was slightly higher with ICE in this study, because probably second venous stick, and maybe there is bleeding problems in those patients. And use of general anesthesia with the TE obviously is the more, and pericardial effusions again with intracardiac echo was slightly more. And this is probably in the early stages as we are doing these procedures. Okay, so that's probably what it is. So I think in similar hospitals, and as we do more, the first ICE that I did, obviously I took longer. Actually, I used both intracardiac echo and TE on that patient to learn exactly what I'm supposed to be watching out and which view and all that. So after doing such 4 cases on one day, then the next day I said no TE, no general anesthesia anymore, and just went into with ICE. And your procedural time also will come down gradually with all that, and contrast usage will come down as well. So I think I'll skip this slide, and as I said that there is not much of a difference, but everything actually in this meta-analysis, it favors intracardiac echo compared to others, but fluoroscopy in terms of room time and procedural time, as you do more, you're going to reduce the time, and fluoroscopy time did not make any difference. And residual septal defect detection, residual leaks are slightly both one versus the other. So leaks are it's the same, and the septal defects are seen more with the TEE. And the cost, as you can see, that there's a slightly increased in this study, it is slightly increased cost with the TEE, because probably anesthesia has to give that time and money. Their money is, the cost is depending upon the time they spend in the OR, as well as the echocardiographers' time as well probably is billed. But at our center, ICE is more expensive than TE by about $1,000, $1,200 or so. So I'll skip this slide and let me just, so I'll try to play this. Can I control this one? So this is what I was showing. Can I swap? Can I have, so every time you do anyway puncture, you do left atrial pressure. I can't control this. How do I control? Okay, so left atrial pressure you have to measure, and so I took away the sorry. Okay. So I took away that the earlier one. So I put a ProTrack wire, because as I said, I don't use the VersaCross, as it again a little bit more expensive. But as you saw, this is a 260 degrees ProTrack. But see how aggressively I'm dilating the septum. So here we obtain two accesses. One is 10 French for the ice, and the other one is usually 8 French, but we expand it to 14 or 15 French depending upon what device you're using. So the ProTrack wire kept going into the left ventricle here, and that's why there's a VT, and we anyway changed that. So then you advance this amulet sheath and 14 French, and we dilated aggressively. I don't know whether you saw that again. And so let me see if I can show you. So that's a amulet sheath going up. So you have to dilate the septum, or you can stick 2 times if you want. But once we dilate it 3 or 4 times usually, or even more, and so the septum is dilated. So once you dilate, you can actually advance the ice probe easily into the left atrium. So people sometimes image from the pulmonary artery, but the left atrium is much better. So you put the ice catheter in the left atrium. So once you're in the left atrium, and you can use fluoro to guide yourself, your ice catheter into the left atrium, and you can see that. So, and so as I said that I was being with my fellow who was first year, so then you can see pulmonary vein and left atrial appendage, and you can measure that, and my technician probably is doing that in the back. And over that 260 centimeter pigtail wire, I actually advanced a pigtail catheter, and the pigtail catheter will be advanced into right now it's in the pulmonary vein. I adjust it and bring it back into the left atrial appendage, and I take only a small angiogram on all these patients because I use diluted contrast, 10 plus 10 in a 20 cc syringe, but I only deliver about half of that. So as you can see, now I'm in the appendage on the intracardiac echo here, and fluoroscopic pictures here. We go into caudal 2020, and then we are advancing the sheet, and so that's done. And once you take a picture, then we try to measure this in the intracardiac echo. These are measurements that we received. So both in 2 views, as I said, you measure them, and once that measurement is done, we do an angiogram as well, and we measure on the angiogram, looking at the shape and everything. And so we know we have to counter a lot. And so in this patient, and so we depend on 2 measurements, angio as well as the intracardiac echo in these patients. And so again, this is another measurements. We have now 135-degree view, and once those measurements are taken, and so we make this is the device preparation that is being done here, flushing, and with the, I think I forgot what size it was at that time, and maybe at 25. I oversize a little bit. So then once that is done, we are advancing now into the appendage. We make a ball, and in the ball we kind of counterclock to go into the place where we want. And do not advance in ball. In Watchman, you can advance it in the shape of a ball. But in Amulet, don't advance in the ball because the tip of it is still very sharp, and you can get into, can perforate the left atrial appendage. So, and then once you're in the left atrial appendage, make into a triangle, unsheath to a triangle, that actually will, you can advance in a triangle easily. Sorry. So, and then once you're on the triangle, so sometimes we have difficulty, we have to adjust both intracardiac echo as well here. So I was happy with the triangle there, and maybe adjusted it a little bit more. And so then actually you can do what do you call a tug. In Amulet, the tug is you pull it back and wait for 40 seconds or 30 seconds minimum and let it go, and we don't push it back in. And so nice deployment, and you can see there were some concerns by my rep in the room, but after looking at a couple of views, we were happy, and then actually I injected again another 5 cc of contrast, and that's the diluted 5 plus 5, and with that we did the angiogram, and it looks very good, and so we finished the procedure, and so we deployed that in that the device in this position. So, and then at the end, you take everything out, and with the check for intracardiac, with the intracardiac echo, check for effusion before you take it out. So, as I said, we discharge the patients the same day, and the clock is in the back here. So I started this procedure at 13:52, and I ended it at 1:43, so it is less than 1 hour. So that's actually, we per-close both of them, and patient actually stays in the hospital for 4 hours, and we do another bedside echo to just make sure that patient can go home that same day after ambulation. So I think so ICE imaging challenging in some patients, and but lower resolution than TEE. I don't know what happened here. And maybe more challenging to exclude left atrial thrombus in some people, but pre-procedural planning does help in some patients. Actually, I don't do it, but you can get excellent results with the more you use, the better you get. And zero peri-device leak is the goal in all these patients, and I think we can achieve that with good imaging, whether it is ICE or TEE, depending upon what your hospital dictates. I think is the best thing to do. Okay. With that, I'll stop here. I'm happy to take any questions. Thank you.
Thank you, Dr. Ramesh. I think it was an excellent presentation regarding the role of ICE in our LA appendage occlusion. I have just one small question. See, we have all been used to doing TE in our patient, and because of the cost constraint in India, is there any specific patient subset which you feel where ICE has an advantage over a TE, and you should suggest that these patients should go for ICE?
Excellent question. So patients with liver cirrhosis where you're suspecting they're probably esophageal varices or history of previous bleeding from varices, I do not want to put any probe, right? You don't want to meddle with that and cause more harm than good. So do no harm first. If you can find an alternative, you should be able to use the alternative. So those are the absolute, and people who you have strictures whom you cannot pass TE probe, again, this procedure can be done with ICE, so we will do it. Mitra clip, we still have not come up to that point where we will probably start doing mitra clips also with ICE. But once we come to that, we'll stop those patients also from sending to thoracic surgery for a stricture dilations or gastroenterologist to do dilations of that.
Any questions from other panelists? Anything from the audience?
Thank you.
Just one last question. Do you make 2 septal punctures, or with 1 puncture only you try to go over?
I always do only 1 puncture, and I never had to do 2 punctures. And but sometimes you can struggle if the septum is too thick, how much ever you dilate, and still the ICE catheter will not easily go into the left atrium. So in those patients, actually, what I have done is put a stiffer wire right next to that other one, next to the Watchman sheath, and then actually the stiffer wire will open up a little bit more than the protract wire. So 360 or 260 centimeters, the Amplat's super stiff wire or Lunderquist wire will open it up a little bit more.
I think.
Yeah, there's always a residual ASD in all these patients, but we don't treat them. Yeah. Yes, yes. Yeah. 10 millimeters is the cutoff to treat.
Thank you. Thank you very much. I think we come to the end of this session. And Dr. Ranjan, shall we go with the next? Or
Thank you for your informative talk, Dr. Ramesh Gadgwadi, sir. And I would request Dr. K.M. Krishnamurthy, Sri Chitra Tirunal Institute of Medical Science, to come on stage to give moment to the dignitaries on stage. I would request Dr. Satish Govind, sir, to come on stage to receive the memento. So next live in Dr. Ramesh Gadupati, Dr. Mukul Kumar, Dr. Rajat Sharma, Dr. Smith Srivastav, Dr. Meeraj Rao. Our year last year. Dr. Ramchandra, Dr. Naveen Chandra, Dr. Sidnath Singh, Dr. Akshay Pratap Singh. So we'll move on to the next session, live in box case. Moderators are invited to the stage. Dr. Bharat Vijay Purohit, Dr. Ramesh Gadupati, Dr. Gopi, Senior Cardiologist, Bangalore, Dr. V.K. Srinivasan, Cardiothoracic Surgeon from Bangalore, Dr. Ragini Dwivedi, Senior Cardiologist. We would request you to come on stage, doctors. Kindly join on stage.
So good morning. I think we are coming to our pre-lunch session, and I'll ask Dr. Anjan to start this session with his live inbox case. I think that is the last live inbox case of this summit. Dr. Anjan.
Yes. Yeah, yeah, yeah. Thank you. This is the last. I think we have this, but this is the last session of the conference. So there are four. There are only three talks. Yeah, with live inbox. So we are starting with one more live inbox case. So volume. Year-old female who has come with recurrent stroke, and the strokes have recurred even on anticoagulation. They had to change 2-3 anticoagulation, and I think total there are 4-5 episodes of stroke. AF since 2013, heart rate control. So this becomes one more indication for LAA, where people with the repeated stroke on anticoagulation ideally need LAA plus anticoagulation. Now, because she's on dabigatran now, dabigatran 150, which is considered the most strongest anticoagulation. Okay. So now we are going to take this one. Back. So hold it. Yeah. So septal puncture, this one. Can you help? Yeah. So we are going to go very slow with 12 o'clock hour. Is the patient straight? Yeah. So we go till the tip. Okay. Yeah. Come. Get the patient little straight, and can you move this one? Come. Move the table down. Yeah. So we're getting the table down. Okay. And as I move down, I'm going to see both in fluoro images are there. We're going to get it down. So this case, we are planning for a Watchman device. We have already done a pre-TV. Some of the images are with you. We're going to get down. We are seeing the septum. We have to make sure the septum is tenting. Okay. So here, yeah, down. Yeah. Now see with the septum tenting there, we'll request. Can the patient be a little more straight? Yeah. So we'll make sure that patient is straight so that the image has no issue. Yeah. Now come. We will be very careful here. Can we see the tenting? Yeah. We'll do it slowly because again it's a poor image here. Is there a tenting? Yeah, I think there's a lower part, maybe there is a tension. Can we see an aortic view? Yeah, aortic view. Any tenting, see? If not, we'll go again. Yeah, see? There, yeah, it's in the middle part. I'm going to go a little more posterior by going clockwise. So this is posterior. Yeah, so this case, the imaging was a little poor, but you can see the tenting happening posterior. It was difficult to pick it up in the other image, but I think by this time all of us know exactly where to puncture. It has to be in the thin part of the septum, but Infero posterior.
In
Yeah.
aortic view, it is posterior. Can we check in bicable? Yeah. Bicable view? Yeah. I think it's somewhere in the mid. It's inferior. Yeah. Mid. I'm going to go little down. Inferior. Yeah, it's inferior.
Yeah. So this should be the ideal position.
Inferior in bicable. Can we record all that? And aortic view again, just to see where the aorta is. Yeah. And yeah, it's away from aorta. We are going to puncture it here and we are going to enter. So septal puncture is done. Record that, please. Yeah, and now we are going to enter LA and we are going to measure the pressure. And we are going to give 5,000 heparin here. Do we have 5,000? I want to give little more because I see a lot of sec and I'm going to give a heparin into LA. 5,000 heparin. Okay? Yeah, with the thermo. Yes. Now look at the pressure, LA pressure. LA pressure in this case is, I know there's a lot of respiratory variation, so she could be slightly dehydrated, but the pressure is 12, 10 to 12, so it's okay pressure. So I think it should be okay. It's written as iota. Can somebody change it to LA? Because the mean will be different if you label it as iota. Change it as LA. Yeah. This is the 5,000 heparin.
So in this, you can see that the catheter is almost here. So the puncture, axis, everything is matching here. But you would still want to do the exchanges here in pulmonary vein. But since it's a watchman, good alignment is the best. You heard Dr. Devi Nair speak about how Mala line produces difficulty. We don't have those steerable sheets. So whatever, we'll have to do it with our standard sheets here. Yeah.
Yeah, so you see LA mean is 13, 10. So I think it's about 10. And we have done the measurement you have seen. So Watchman flex is what we are going to use. And that we have to be, the sizing, anatomy, everything.
So the question is, how would you size it? We are trying to do a watchman fax. So this would be where the circumflex is. There's a lobe, one lobe which goes up, one lobe which goes down. You'll see it in angio. We would want to measure this size. It's a watchman, but you would still measure this because you want to cover everything.
Right.
And ideally, you want to be on this lobe later. The pigtail, if possible, should be on this lobe and not this lobe. And you'll upsize. Imagine this number comes 18, the device will be 22 plus, 22. The next size of watchman flex is 25, but most of us, Dr. Ramesh will agree with me, we try to upsize even little more because compression is needed. This is not possible with ACP or, Amulet ACP or Lamre. You don't upsize too much. It's 4 to 6. Maybe even 3 to 4 is fine depending on this. But here you want more and more upsize because then the compression is better, embolization chance is lesser. More compression, lesser embolization, hooks will be open, and also the peri-device leak. If you don't want to do all those steps which Dr. Devi Nair did, they didn't look simple. Better to avoid it right. So alignment, sizing, all that matters to get, prevent peri-device leak. We shouldn't accept any.
Is good becomes very, very important. Now I'm going to take it to the pulmonary vein and septal puncture is done posterior inferior back please, and we are going to take it to pulmonary vein. Yeah, and then pulmonary vein and then pass. Okay, so pass the wire please. Yeah.
I don't know whether you looked at the coordination. Moment I told pulmonary vein, actually she's actually showing the pulmonary vein. So this is a two-person. That communication has to be there. Immediately the whole thing shifts and they know. As soon as the wire goes, they know that you are in pulmonary vein. They'll tell you and the whole procedure becomes very...
Pass the wire. Yeah, it's going to appendage. So hold the wire, hold the wire. So again, can the patient be a little more straighter? Yeah, because otherwise the anatomy becomes very difficult to figure out. Yeah, this is pulmonary vein. Can you save it? So where we
want you to look at the T wire going. Anyway, fluoro, it's very clear, but the T wire going also is important.
Want to take it. It's always preferable. I believe that it's always preferable to change things in pulmonary vein. And can we keep the amp-lancer wire? Okay. Now we'll take the, watchman comes with their own sheath. Which one? Can you put it here? So Watchman comes with their own sheath. So we have done some measurement. I think Kavya has done measurement in different, it's a multi-lobed appendage, lot of sex, so we have given more heparin, and we need the flushes there, please.
And the other thing you notice is once you give heparin, the sec disappears. It's important. This is more thrombotic than BMV. They are older, they are elderly, so more thrombotic, give more heparin.
For to flush the device, that this one flush system is needed. And then we'll take the 14-pin sheath is ready. So Watchman comes with its own sheath, which is like a double curved sheath. I'm going to keep it in pulmonary vein. Yeah, get the patient straight as possible. And we're going to remove this. Is the 14-pin sheath level available? Come. We're going to remove this. I usually use a femoral axis sheath to prevent this. So you can see in the echo beautifully how the device is in the, this one is in pulmonary vein, 23, right? And the depth is around 30, 31, or 29. So there are some measurement which I think only the live ones they can record. So one live measurement can you take away? Yeah, because they are not able to take the source from that. So let's do one live measurements in maybe 135 this one, and then we'll keep. Yes, can we get the sheath, please? When the sheath is ready, and if you are ready to take the sheath is ready, come. And the flush is ready. Ashwin, you have to be little careful on the wire. Yeah, hold it straight. You have to remove the sheath. So the groin, I think Lakshmi will compress. Yeah. Now moment you freeze, I think it is not there, Kavya. So you can show one, moment you freeze, it doesn't come. We could have only take this. So we will take this.
So our lab has echo navs. So the echo machine is on this side. It's connected to the fluoro. You can even mark your point, septal puncture and appendage. We don't mark, but we use that screen to see. But moment you freeze, the measurements don't get transmitted. Then you'll have to check the measurement from your echocardiogram.
So
this is taken from the source.
The echo is so useful. It is showing us exactly where our wire is, which is in the upper pulmonary vein. Wrote the pigtails here. And as I keep telling, pigtail should lead the system. You can see the sheets now actually in the pulmonary vein, but I will allow the pigtail to lead. Can we have the flush ready? The water flush? Yeah, the water, this one? This is the one? Yeah. Can you open it? Yeah. So total heparin is 7,000 here, and we're going to start it slowly. Now start pigtail on this. So having a wire, I find it much better to take the pigtail in whenever you have to take the pigtail. Now hold the wire, and we will take the pigtail in. There are more than one way of doing these procedures, but over the period you see what suits you best and you take it. So here is the pigtail which is now coming there, and I'm going to remove this one. So pigtail is leading. At this point, what we'll do is I'm still keeping the wire. We'll come to RAO view without hitting people. Let's go to RAO. Yeah. And you can, there's a slide that whatever you're seeing is because of the flush, the bubble. I'm going to decrease the bubble, this one. Now the whole system, we need some dye. Keep the dye ready. The whole system, we're going to pull down, and I'm going to allow it to fall. So please be ready. This is plain RAO. I want plain RAO till it comes down, and then we'll come to caudal. So RAO here, yeah, now follow. Now you can see that the whole system is actually falling down. I'm going to pull it very, very slow, and it's fallen into LA, and you can see it in echo, how the pigtail circle is seen. Now
this is the step. You allow, you can see there, you pull it down, it falls, and it's just there. All you need to do is push the pigtail. It just walks into appendage.
Push it gently, it's likely to go to appendage. So you can see it now go to appendage. And if I anti-clockwise here, it will go to the upper lobe. So
this is what we were saying, After that, make it look up. And then, if needed, take an implanter wire there. Not outside. Just to give that little extra stiffness because things don't go. And this sheath will, with the anti-clockwise torque, will go. You want the sheath also to look up in that position and uppermost lobe. Always the uppermost lobe.
Where we are. We are in the upper lobe here. That's how we enter the appendage very slowly. I'm going to keep the implanter wire in the tip so that the whole system, it gives some stiffness. Let's keep it like this, face like this, and hold it like this, okay? So that nothing is moving. Slowly, I'm removing the sheath. Yeah, I'm moving the sheath with the, once I read there, I'm going to give some anti-clockwise torque. Ashwin, you have to hold it here. Yeah, yeah. And we have to hold it with the, yeah. So I'm going to pull it like this and keep it here. Okay. And so that's the position you want to this. You can take an angio there. That will tell you exactly where the device is likely to land. This point, we can take a now injection through the pigtail or through the sheath. I generally prefer through the sheath because it will tell us exactly where we are. You know, yeah. Now it is RF caudal, yeah. And dye, little more dye, because you need the dye to fill the catheter. And the best view to work with this one is RF caudal. Little more dye, 20 cc. It's dye? Yeah, yeah. Keep it ready. And now, after this angio, we are going to decide on the this. Okay, ready? Cine, center it, please. Yeah, I'm going to take a cine, center it, please. Yeah, I want it center, unnecessary things taken out. Ready? Cine. Yeah, this is how the appendage looks. Now it's quite a roomy appendage, and there is an upper lobe on top, and I'm somewhere in middle lobe. It's preferred if the pigtail is actually on the upper lobe, the one which we saw in 135 view. 135 in Nico is the right view, and there are markers there. First one is 21, the second one is 27, and third one is 33. This is meant for the old device. The new device comes with a different size. So our measurements, almost all of them show 23, 24, almost a circular orifice. So we are going to take a 31 device, and it looks good to me. But before, so 22, 23 actually means 27, but upsize one more size, that is better. Again, you know, there is this appendage, you see like a chicken wing there, you know, it just bends and goes up. So before the device, we would like to take the pigtail into that lobe so that it becomes more this, and it's quite roomy. It's not like the case which Dr. Purohit showed, where it was very short and it was turning around. Here you have some space, you'll be able to put watchman flex here. For that, I would like to, if possible, you know, put the pigtail on the upper lobe like this with a slight push. This is also the reason I take with the sheath, because I don't want to remove that wire. You know, without wire, the pigtail will start, it is very flimsy. So the wire is always kept inside. Yeah, okay. And this gives extra stability. Push the wire inside, hold it. Now it's the holding time, and then we go like this. See, now we are more into the upper lobe, and I maintain the anti-clockwise torque. So fluoro save that. So this is how the device should look when we start implanting. Can we show the cine once more? Run the cine. And that 135, see, there is it's a bilobe, right? You can see one lobe here, one lobe there. We want that lobe to have the pigtail and have this one. So, you know, you plan it well, you do it slowly. Don't be in a hurry to load the device. Get, you know, understand where you should be before you start slowly, and then that's the way to do it. Yeah. So I'm going to be starting little distally. If it is 31, we'll be somewhere here. Might have a slight shoulder, but if I can start it a little more distally, it is good. Good. Now let's come to the device. We have decided 31. So 23, the right size is 27, but it's good to upsize one more so that the peri-device sheath is very, very less. Okay. So Lakshmi, you can hold this. Yeah. So let's get the device. It comes preloaded. We need to see, we need to flush, and we need to see. So no too much pushing, no too much pulling. The steps have to be precise. Again, you see a two lobe here, but the upper lobe is the one where we have to start. Anti-clockwise, upper lobe. That's what we want to do. So we are here. We need to flush with a 50 cc syringe here as much as possible. So I don't know whether you can see the device. Yeah, yeah, I can come that side. Yeah, so this is the device. What I'm going to do is we're going to loosen its light. I'm going to position it. The tip of this is okay, it's very soft, and we are going to get tip exactly at this point. And now anchor this, close this, yeah, and start flushing. Yes. Okay, so this is how we flush. Slowly, more flush, more flush. There's always air in the system. You may have to tap it. And we also have the flush ready. The second flush, please. The second flush there, yeah. Or we, yeah, yeah. Start. Yes. So we flush, we see it's quite good. I'm going to connect that flush here so that the air is fine. Yeah, come, bring it here. And I'm going to, there's a marker on that, and that your device should exactly be there. If it is front, because that's the marker which you see later, and you have to adjust it to that proximal marker. So first, and it comes connected, device could be packed for a long time. So you'll have to do a pull and push, make sure it's moving okay. Then the topmost of the device should be adjusted to the marker. So this sheath is, that's different sheath, this is different sheath. That is the sheath which comes with this. The my pigtail only at the end. Before that, hold it here. Yeah, leave. Yeah, thank you. So we're going to lock this. We're going to connect the flush to this point. Connect it there. Remove the flush. Yeah. And run it. Yeah. I'm going to here. And can you flush the air again? Yeah. So this is a good way to de-air it. And once the fluid is going in, I don't see any now. Yeah, tighten it. Yes, and the point is ready. Okay. So I'm going to recheck now where my sheath is. I'm also going to, can you just check, Ashwin? Keep that. Yeah, can you just check with the dye? Because I'm going to start. We know we have to start a little distally. Yeah, test. Yeah. Yeah. So see, it's like a chicken wing there, which is going. We have a lot of space. I would like to take this little more up and take this little more inside. Okay. Now with this, I'm going to remove this with the anti-clockwise, and sheath went in little. I'm not going to test here. We're going to see it in, get the device. Okay, we are going to, yeah. Can you see the tip of the sheath? See that in Eco 135, I was actually able to show the tip of the sheath. So we are going to go very, very slow. And this helps me that I may be touching. I've just pulled it little back. So I pulled the sheath little back because it looked as if it is touching. This is the dangerous place. We have pulled it back. There is anyway dye in the sheath. So as you put, you see where it is. Too much testing is, so we release the sheath here. So this is a little dangerous step when you use Watchman because you're a little more inside. Can you decrease the flow because there's a lot of bubble? Yeah, hardly any, just a drop. This looks like a good position. I'm going to take it. The bubble is because we are giving the bubble here, and we are going to go very, very slow. And I maintain the anti-clockwise and made sure there is no air in the system. The air is actually coming from this. Now slowly, and this. So LA Cordon is the best view for this. We're going to take the device in. I'm going to take it in further. And this is the point where we wait. See, both the markers now connect. This point you don't push, but you pull. So I'm going to pull the sheath back. I don't know whether you can see it, and lock it. Pulled back. Now Kavya is observing that very well. Anti-clockwise is maintained. Now I'm going to unsheath it at this point. There are multiple ways of devising, but I would want to start distally and no push but pull, unsheath with a good anti-clockwise, and we are going to unsheath it further, allow it to form a bleb, and ask Kavya to see that bleb. I think we are still more deep. I'm happy with the position. Still not visible, we may be deep, but it's good to be deep, and this is how the device. Now look at the device. It's open, it's in a, there is a good shape of compression. We're going to do the echo and test whether it is fine. Obviously, you can see some shoulder there, but the compression is extremely good, and I don't think so when you have something like this, you'll have a peri-device leak. So I'm going to, and very important step, you have to do a count of 10 with this. 10 times you have to push. So I'm going to do that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 times there is a count of 10 which is done so that the device forms, and with the push I'm going to come back. The shape looks a little different, but I think the position looks very good to me. Compression looks good, and there is absolutely no peridot. Look at 135 because that's where it will look funny, but you can accept some shouldering here. Kavya will do some measurements now, and then we'll see what to do. I'm also going to pull it a little back to see whether there is stability. It's a good stability. There's a good push. So with this, when it endothelializes, it should be fine. Can you do the testing? Yeah, measurements. So we do pass test. Pass is position. Position looks good here. A is anchoring, I pulled and saw. Next is size, which he is measuring. The size measurement is very important. I don't know that we are not able to show, but it has to be through. What is the number you're getting? 21. So 21 to 22. Now 21 to 22 would act.
So when you measure size, this should be there. It should be, you can't measure in any position. You have to, I think I'll pause.
Pass is position. Position looks good here. A is anchoring. I pulled and saw. Next is size, which he is measuring. The size measurement is very important. I don't know that we are not able to show, but it has to be through. What is the number you're getting? 21. So 21 to 22. Now 21 to 22 would.
It should be measured at that point. You need to see that knob and that junction. Otherwise, it would be foreshortened.
Would actually mean that the compression is around 30%, which is very good. So we could have taken one step smaller, but the bigger one, if you can put it, is always better.
Yeah. So this is a exactly nice picture where you can measure, and you have to measure a little bit probably on the monitor. I mean, anyway. Yeah. From here and to here, you can measure, draw a line from here to here. Don't draw it from here there. So that's not the one. Slightly lower in the shoulder, exactly where it becomes, and draw there. And
Not
that's
here.
Yeah.
It should be the widest of the device with this knob. Don't see the knob, you're foreshortening it. You'll get a number, you'll be happy. But with this, if you're not compressed enough, it could embolize. Those are the cases which Dr. Horse showed. You might feel it is very stable, but compression is also equally important. Yeah.
Without risking, and the shoulder is not too much here, and the shape looks good. You want to do angio, we can do angio. Can you get the dye? And the position look.
This is a good position. See, you can see it compressed here, covering everything. And because there are two lobes, I think this will be the best position to cover both. What do you think, Doctor?
Yeah, no, absolutely. I think, you may still think that there's a gap, but you will not have any flow right next to it when they put color.
It's good. And now she's going to look at the peri devices. So nowadays, we do not want any peri device lead. It's a self-adjusting device, which is slightly, I think the position is good considering what it is. And this is the contrast here. So that's not going to work on that now. So it will work on this. So we are going to take the dye here. And I'm going to take the, we have locked everything. Yeah, ready? I'll take a cine again. Yeah, it's good.
So whatever. Though we are doing this for the live case in box, but both of us don't practice in different countries, don't use any contrast to just check it. If the patient's creatinine is high, what's the point of giving extra contrast? Because TE is fantastic images and no PDL, nothing in there.
And whatever
the seal
little
compared to
contrast
what
is, this is through the fabric. When it endothelializes, we don't want to see anything going from here or here. Through the fabric, still the flow will go. It allows it till it endothelizes, which is typically around 45
seal
days.
is good, shape is good, position is good. I feel this is a good position and there is no peri-device leak. I'm going to pull it once more just to make sure the anchoring is good. I feel anchoring is very good. I'm going to push, and if Kavya is comfortable, we can release. Yeah, let us check everything. This is the time when we should not be restless. We should wait. We should see the, the covering is more.
And as Dr. Horst was saying, pray.
So there's nothing to worry. There's absolutely nothing peri-device. Position also looks good to me. So good anchoring, good compression, good size, and absolutely no peri-device leak. So I think this is good. What number are you getting now? 22. So all numbers are fine, and she has reduced the threshold to see that there is no flow across. You can put it live, I think, to see whether there's any flow through the fabric.
For flow, the Nyquist limit, it's a venous system, practically venous system. So Nyquist limit has to be reduced, and then you look at the peri-device flow. Yeah.
That can happen, but more important is to through the flow. So the sealing skirt can be seen. It's beautifully sealed there. Yeah, that's the sealing skirt, and that is good. And we'll look at the flow across. I think it is good. If it is, yeah, it looks good. So I think there is absolutely no peri-device. We could have taken one size smaller, but this is the optimum. I'm going to release this device and probably not do any angio after that because there's no need to do. And release is at this. See, post-release, it self-adjusts. It's actually good. Position is good. I think it's a good position and everything is fine. This patient will be on anticoagulation.
Yeah. So this is one patient who had recurrent stroke on dabigatran, did not have any bleed, but there are recurrent strokes. So 3 to 5% of people actually have recurrent stroke. They had changed 2, 3 anticoagulant. She was on Eliquis and shifted to, Pradaxa and things like that. So this becomes one more indication. But such patient, you don't stop off anticoagulation. You do this, but continue anticoagulation, and you could reduce the dose, but she, I think, had 6 or 7 strokes in last 6 or 7. Very smart lady, actually, was a professional and but ended up with multiple stroke, understands the whole thing. So we explained that we're going to do this, but we're going to continue anticoagulation. This is not an alternative. These are high-risk group. They tend to have recurrent stroke. I'm sure all of us have seen, your neurologists have seen. There are times, you don't even get time to do LA for them because the strokes are so frequent.
Even after finishing the procedure, is the sheath. And also the whole ridge is going to.
Then there was a figure of 8 and we closed.
Okay, thank you very much. Fantastic live in box. Any comments on?
Thank you, doctor, for your wonderful speech. Dr. Ranjan Shetty, sir, thank you very much. Next, we call LA closure in ASD by Dr. Edwin Francis.
Morning, everyone. Thank Ranjan and the team for doing this conference. A great meeting, good attendance. And then just for the next 5-10 minutes, probably I'll quickly go through like my experience with simultaneous closure of ASD and LA appendage. So to start off, like I'll just go through introduction, indication, procedure, and what is primarily different. When I started off doing this as such, LA closure was itself rare, and then doing it together used to be even more rarer when I did my first case in 2016, 17, 15, 16, I think. So, and then there was no clear guidelines to go by, and the only thing I went by is by the each entity required had an indication to close it. Like obviously, if you have an ASD, obviously that has to be closed. Sorry. But then if you have a PFO closures, LA appendage, obviously had its own reasons and indications to go in. But then when I go in to close an ASD, those patients with a chronic atrial fibrillation, I give them an option of probably closing it and LA appendage, because once I close an ASD, if the patient gets into trouble on oral anticoagulation, it's going to be difficult. You technically can. I've done perforating an ASD, put in a stent for different reasons in different scenarios. But in a routine case, it's going to be difficult to poke through the fabric, get a big sheath in, and then close the LA appendage is going to be difficult. So these are indications for which the first patient had a problem, had a bleeding tendency. So they had a case in which just did it. So then I offered a few patients, so that series was done around 5 or 6 cases. So obviously the patients did have a large ASD with, all patients had a large ASD with chronic atrial fibrillation. Obviously almost all of them had significant stroke and bleeding risk. So they were offered this simultaneous closure. And they were given a clear, informed consent that probably once I do the procedure and then an ASD is closed, then because they should be aware that I may not be able to do a LA appendage so easily. So many times, many of them patients are willing to do, but then the financial problems made them a limited number of patients could take the procedure both together, because at that time I remember, like, I don't think Lamprey or LifeTech devices were not available. So the only available, the Watchman and the Ambulance one was quite expensive. So already have an ASD device closure, and adding on to that, it was mostly not possible for majority of the patients from our part of the world. So, depending on the procedure per se, is it not significantly different, except that I don't usually go in and do a puncture. I just go through the ASD. Obviously, it's a large ASD sitting there. So the benefit probably is that you can avoid a septal puncture and the related complications. So in majority of the literature, the major complications related to the LA appendage closure was mostly due to, I think, as the atrial septal puncture, because probably in this part of the world we routinely do atrial septal punctures for PTMs, balloon mitral valvotomies, but probably in the Western literature they may know doing less in the probably a decade earlier. Now with a lot of mitral interventions coming in, there are a lot of interest in atrial septal puncture and with the atrial fibrillation for the electrophysiologist. So the major benefit is that you don't need to cross the puncture the atrial septum. But then that could be a concern also, because like the PFO, like a smaller ASD or an even larger ASD, majority may be more related anteriorly and superiorly. So the entry into the LA may be difficult. So I still remember, like, we are doing, I think, with Cybercar is one of the best in the mitral valve interventions, in one national CSI, a live case. They had difficulty, like he started off the case, like a difficulty in entering into the appendage, because as most often they do with the atrial septal puncture. So along with an ASD, we actually entered with a multipurpose catheter, entered the LA appendage, and then maintained a wire, stiff wire, and then that took the sheath directly rather than going to the pulmonary vein and moving in. And the stability of the long sheath is also going to be difficult. Like the usual recommendation is to go into the pulmonary vein, come back. But then because the large ASD, it will not have any stability for the long sheath, the deployment sheath. So it may not be able to maintain that position. So in those cases, I probably many a times go directly to the LA appendage. As yesterday, as Dr. Sievert or Ringen was mentioning, that I don't use the long floppy wire. I tend to use a short floppy. Either you can use the Amplats stiff wires come with 6 centimeter, 3 centimeter, and 1 centimeter floppy. I preferably use either 1 centimeter, 3 centimeter. But when you're using a 1 centimeter floppy, you'd be very, very careful, because just for a centimeter beyond that is going to be very stiff. So I would probably recommend using a 3 centimeter floppy wire, so that you have some floppiness inside the appendage, and then slowly introduce your sheath, either your double curved sheath, or I even use a routine Mullin sheath, which I use to close the ASD device. So these are the few limited concerns when we do this ASD with LA appendage. But I think there are many pediatric cardiologists here. For those we are regularly doing ASD devices, I don't think this is a problem at all. It's more important when the adult cardiologists try to do LA appendage with an ASD, going to be difficult. So coming for the reverse way, when you have finished the ASD device, when an LA appendage closure, when you're doing an ASD device, the problems are not too many, but then your manipulation should avoid the embolization of the already deployed LA appendage device. But when you have a very difficult ASDs, difficult margins, probably you will not be careful in doing it. And then a pulmonary vein technique is going to be difficult. So you may have to use a right upper pulmonary vein technique, or you may use a balloon technique, will be more safer to not to dislodge the L appendage already deployed. Another important thing, I usually wait at least around 15-20 minutes before I release my ASD device to make sure that our L appendage is still in place, it's not embolized at all. That's what I haven't had any embolization till date. And the complications wise, as I said, the complications are predominantly due to either the septal puncture or manipulation with the LA appendage. So it used to be either same, the only few studies which came up in the last year or two. And because the complication rate are either the same or marginally lower when you combine both. Another important thing I found is the LA appendage per se is not quite distended. When you have an intact septum with a chronic atrial fibrillation, you have a significant stretching of the left atrium, and probably both atrium, but more often the left atrium when you have elderly people with diastolic dysfunction. So the left atrium appendage is going to be more distended, and you end up using a larger devices. So they are more difficult, and chance of embolism may be higher. But in an atrial septal defect, where the LA is easily decompressed, the distension and the dilatation of the left atrial appendage is far lesser. So I think the complication rates could be marginally lower. That is not proven scientifically, but I think it's can be done. Studies can be done. This was one of the only few papers I could find. It came in, I think, 2020 in British Medical Journal, in which there's a one-stop to see the efficacy and safety, in which I think they did 25 cases of either of them. One was PFO, one was ASD. In my case, I haven't done any PFO associated with LA appendage closure because most of my PFO closures are younger patients, so cryptogenic strokes, which I usually don't have a reason to close the left atrial appendage. So in this, they found this quite safe. It was a 2020, this article came in. So I'll just give you one or two examples before I wind up. This is a case in which I said we did have difficulty in going in and entering the LA appendage because of the more anterior superior atrial septal defect. Actually had to have I used a multi-purpose catheter, went in, entered the LA appendage and did my angiograms initially with that and later on. So it's probably not go by the typical recommendations. Probably you have to slightly improvise depending upon the scenarios. So in this case, I have initially did the angiograms, positioned it with a wire, went in with the amplathe strip wire, then took the pigtail and the sheath in, because I think this I did with Dr. Saibulkar, I think. So this was initially difficult, but then once you're in, well deep inside, then things are all the same, just like any other LA appendage closure. Another small tool, probably if you have it, in this case I think used, like I think that's the previous case Ranjan was mentioning about the echo navigation. If you have it, probably it can be useful for few cases in which you can easily enter the LA appendage. Like the next case which I'd use echo navigation to help it enter. But then here you can see the first slide, you can see the pigtail going into the, so you can mark it, like you was saying he didn't mark it. Echo navigation, you use, standardize it and then mark the position. So the entry into the LA appendage become quite easier. And then you can see, like once the position is there, I do a small angiogram to confirm that it is in place. So it is probably additional tool. If you have it, you can use it. I find it more useful when I do close the paravalvular leaks, but less often I use it in the LA appendage. So once the position is confirmed, and then I went ahead and put a 28 mm. This was an amulet device which is deployed. I form a bulb here, make sure the position is good on echocardiogram, and then I went ahead and deployed the whole disc completely. And here is the another important thing. Obviously, the stability is of paramount importance, because unless it's stable, I put an AC device and go home. And then if the LA appendage is embolized, I'm going to be in trouble. But according to I haven't had any LA appendage in embolizations. But in the yesterday's talk, Horst Siebert was seeing most of them as going all the way into descending aorta. Then it should not be a problem. I can retrieve it from anywhere beyond that. Otherwise, it's going to be not to be easy to go through a ASD device. Recently put an ASD device. Obviously, you cannot poke a like immediately deployed ASD device unless it's at least 1 or 2 months old. So here I make sure that with a good tug and make sure it is well in position and stable, and then go ahead with the release and make sure there is no paravalvular leaks. But para device leaks. And then I went ahead and put a 28 mm ASD device here. I think this was an ambulance device, and deployed the device, and then make sure this was stable. And even if a device is embolizing, is also a difficult problem, probably if you have the two device, LA appendage device also sitting there. So the major concern in this, you have the possibility of either of them embolizing, and ASD device embolizing probably most often happens to the right atrial side. RA or RB probably can just go ahead and retrieve it and put a bigger device or send for surgery. But otherwise, an LA appendage device embolization is going to be catastrophic if it stays in the left atrium. To give you one more example, and here it was another lady with a 75, 76-year-old with a large ASD with a chronic atrial fibrillation. Here again, I usually directly go in after my 10 or initial 10 or 15 cases. I probably don't do the pulmonary vein technique. I directly enter into the LA appendage, especially when you have a large ASD, then it may be difficult to maintain the movement. So I directly go into the LA appendage, put a short floppy wire, and put the pigtail and the sheath, and then do the angiogram. Here, the Lambre device is being deployed, and with the TE guidance, obviously, most always do a TE guidance. Another method sometimes I do is I have a clear measurements taken in the preoperative assessment. I might go in, do the septal puncture, everything, and then position it, put a put a TE without general anesthesia, make sure my position is good, and then take it off. I will not go through a full general anesthesia. So this is a Lambre device being deployed. and then find this slightly more easier and quicker. And then even if you oversize a bit, it is unlikely to emboline because that umbrella tends to get compressed more easily. So the position has been confirmed, and after that, I again check angiogram to make sure there is no leak, and go ahead and make sure the stability is again, I both an echo and fluoro, make sure the stability is well clear by the tug test, and following which an ASD device is being deployed. This is a very like 24 straightforward defect, so I could easily deploy the defect. And then here is fluoroscopic views of the ASD device being deployed. Then you have the final position here in which both the devices are stable. So this is one of the recent, one more article came in the year last year in which again they combined they did a meta-analysis about the feasibility and safety, and then they came out with the conclude that it is quite as safe as a LA appendage alone to do both the devices together. So to conclude, the LA closure can be combined with any of the other structural interventions or elective cell intervention. Yesterday we had Dr. Arun Govi presenting his beautiful case on the ablation with an LA appendage closure or a pacemaker with a LA appendage closure, but then you can do other structural interventions also along with it. It's quite safe and pure to do it. Thank you.
Sir, I have to ask one question. See, usually we go to posterior inferior puncture.
No, I'm talking about an atrial septum here. I mean ASD here. So I don't puncture here.
See, the question is different, sir.
Yeah, sorry.
But in case the ASD is anterior superior position, so is there any special maneuver to go through that anterior superior ASD and enter into the LA appendage?
Yeah, that's why. But sometimes it might be difficult. That's why I say
Yeah.
I mean, don't know specific thing. You have to go by your like talking and all because it's a large defect. So you cannot do. You may do an anti-clockwise tilt. If we look at the pediatric cardiology, we have seen like when I was training, many of the fellows end up poking through or perforating the LA appendage. I've seen at least during the a decade earlier when the devices was first in early 2000. So many a times what I've seen is we end up while doing an ASD device, many of us have ended up perforating the LA appendage. So probably it is not very difficult to go into the LA appendage. Either you can use a multi-purpose catheter or a RCA catheter and then actually take an anti-clockwise turn. When you take it anti-clockwise, it turns anteriorly. So LA appendage is a more anterior structure, unlike a pulmonary, it's slightly more posterior. So instead of going to the pulmonary vein and coming out, you probably directly enter the LA appendage first, keep a short, floppy, stiff wire in the LA appendage, and then gradually, slowly push in your big tail angiocatheter.
So the problem will be more for PFOs than actually ASDs.
PFO will be more
because
difficult
of
probably.
it's a tunnel,
Yeah.
you know.
So in the case of PFO, you have difficulty, probably you may puncture again. But ASDs may be not be that difficult. When you have a PFO, it will be almost invariably anterior and superior located. So when you have only a PFO, in one article they had a PFO closure with LA appendage closure. So in those with having only a PFO, it may be more difficult if you are not well versed in manipulation of structural interventions. In that case, you may have another additional puncture posterior to it. It's not a big deal in that case.
And second question is, you directly entered into the left atrial appendage, not going into the pulmonary vein. So is there any benefit in this case?
I find it again the stability of the sheath, unlike in a regular puncture, infra-posterior puncture, your direction is quite into the LA appendage. So when you drop down, it quite easily goes into the anti-clockwise tilts and come down. It just goes into the LA appendage. It may not happen when you have a large ASD, which is not restricting your movement. I mean, it's freely moving the sheath. So it may not really happen. You can try that. It may or may not happen, but many a possibility that it would have difficulty. So your routine mechanism may not work here. So you may directly go to the appendage instead of doing the regular recommended technique. That's what I mean.
Thank you.
Any comments, Dr. Purohit?
I have just one small question regarding the timing of this ASD device closure, because we are all familiar of late period device clip, which can need a second intervention in future, as shown by Dr. Nair also in the morning. So do you think that it is a good idea to close both the things together, or it makes sense that because this is an adult patient who has ASD for almost 30-40 years, he can still wait for another 6 months and to see whether there is a late peri-device leak which is not there and then come back again, because I don't think there is any cost benefit of doing it together, because ultimately the hospital is going to charge for the two procedures.
No, maybe
So
you can probably get ask them to reduce the charge. Obviously, that's the only way we can save. Yeah.
Yeah, so I mean, actually, in the United States, it's only one charge. You know, we just did one procedure recently, both ASD and left atrial appendage occlusion, but it's only one charge. You can don't buy one get one free. I said, you know.
Definitely,
I
the
think one.
procedure charge will be definitely cheaper. Like we maybe charge for the device. Obviously, I will not charge for both the procedures. Definitely.
So I think one question from the
Sure,
audience.
Srinivas.
Can,
One question, sir, about the sizing of this appendage. You said that these appendages are relatively smaller when compared to the patients with no ASD.
Relatively
Do you
smaller.
normally do a balloon occlusion before you assess the size of the appendage, or you don't do it?
Balloon occlusion appendage.
But yeah, balloon occlusion of ASD to assess the size of the appendage.
No, I don't do that. I never done that. Maybe it may not be a bad idea, but then so far I haven't done that. Maybe like well, probably it might suddenly increase when LA pressures probably that maybe somebody's it can theoretically can happen probably once you close ASD if the LA pressure goes up there's a further distension can happen then LA appendage theoretically
leaks can be
move on.
so
But
will
that's
be
a
appropriate
good,
in sizing.
good thought probably.
Yeah.
But then thankfully I haven't had trouble. So
So the only concern about actually, as you said, number one, you need to have two indications, each for itself, by itself. And just because you have seen an ASD doesn't mean you should close everything, because most of these patients are atrial fibrillation patients, left atrial appendage closure patients, and they probably need to undergo further procedures in the left atrium for whatever reason. So if you close it, it's not that you can't go back with a transeptal puncture next to it or through it and do whatever your PVI procedures you have to do, but it becomes a little bit more cumbersome. So I would, say that make sure that the ASD meets all the criteria for closure.
yeah, definitely.
Yeah, it's not really that just because we see one and
Yeah,
close
but
it.
ASD, we are not looking at PFOs and all. That's why I never had any case of PFO with LA appendage because I find it, I didn't have any case, obviously. But in this study, they had some 25 cases of PFO with LA appendage because when you have an older patient and there is a clear cost, I would probably address one. And then if there is still occurrence and there's a PFO shunting right left, I might go in. But then I never had such a case like that.
All right. Yeah. Thank you.
Thank you.
Thank you, Dr. Edwin Francis, sir, for your informative talk. And next, we move on to LA closure with ablation by Dr. A.B. Gopala Murugan, sir. Please come on stage.
Okay. Good afternoon, everyone. Thanks to Ranjan Shetty and Ravneesh Dagubati, in respect to the chair. Because I'm the last talk, I thought it would be very silly to teach you how to close LA appendage. So I've closed all that slides. So I've deleted it. And I will just go through a little bit about why would you close the appendage at the same time as ablation and give you some evidence. When and what ablation would one close the LA appendage? That's the first question to answer. These are arrhythmias that are associated with the strokes and patients who have a high Has-Bled score. Naturally, the arrhythmias would be atrial fibrillation and atrial flutter. One of the advantages of doing both is you tend to offer a one-stop solution, everything in one procedure. And by saying a one-stop solution, it's a value-added benefit because I think you all heard this. No one gets any better by doing an LA appendage closure, i.e. symptomatically. You only prevent strokes, but they will get better if you do an AF ablation. So if you do an AF ablation, you cannot prevent strokes. This is the evidence. You can only prevent symptoms. But if you close the LA appendage and ablate the AF, you get rid of symptoms, minimize or perhaps negate the risk of stroke, and come off anticoagulation. This value-added benefit can be a good aspect to do it in a procedure in one patient who deserves the most. Evidence and recommendations, there are plenty of studies you can look through. This is time-tested for over 8 to 9 years now. Combined atrial fibrillation, this has been published in a large study. This is a 350 patient study where they found over a long-term outcome that the evidence suggests that combining AF ablation and LA appendage is feasible, safe, and successful. This is not just in the acute setting. And when they followed it up long term for 4 years, 5 years, they reduced strokes and bleeding in these patients because they were all off anticoagulation. So there is an added benefit, there's clear evidence, and many patients would benefit. Ablation LA appendage closure, I think from a technical perspective, it's very easy because you're anyway in the left atrium. You've ablated the arrhythmia, and once you've ablated the AF, it's very easy to just do the LA appendage closure also. Of course, all these procedures will be under GA because you have planned an LA appendage beforehand. Procedurally, I think AF ablation, I wouldn't spell too much. You largely need 2 transeptals, and once the ablation is done, the first will be the ablation procedure, and the next will be the LA appendage closure. There's one technical aspect, which is the transeptal procedure. The transeptal for LA appendage is completely different to a transeptal for an AF ablation. AF ablation, I usually prefer a very anterior puncture because you want to be able to turn back and ablate in the right upper and right inferior. But for an LA appendage, you want to go posterior inferior. So for transeptal, if you're going to close an appendage in the same sitting, make sure you do 2 transeptals, 2 independent, though double sheath it, 2 transeptals. The first will be for AF ablation, which will be an anterior, and next will be an LA appendage closure transeptal. So that's why they're always separated nicely. What this means is you still will have 2 catheters for the AF ablation, one for the mapping catheter, one for the ablation. Finish your job and then swap your appendage closure device to the posterior inferior one for the LA appendage closure. So that's from a technical perspective. This is the most important aspect when you want to combine these 2. Patients sometimes may not present with one pathology, they present with more pathologies. So I thought I'll give you a little example how this one-stop solution can be materialized, providing a very cost-effective option for a patient. This is a 78-year-old man, shortness of breath, chest pain on exertion, and he had syncope. Because he had syncope, he knocked his head and had a subdural hematoma. And that's his ECG. I think I don't need to spell it out. This is clear atrial flutter with a high degree AV block. Therefore, we did an angiogram, of course, because he had angina and had significant instant restenosis of a previous stent that he had done elsewhere. So the issues here in this elderly man is he had angina due to dominant vessel occlusion, shortness of breath because of the atrial flutter and perhaps angina equivalent, and syncope from the high degree AV block, and clearly high stroke risk because he's elderly and he's got atrial flutter, and also he has a high HAS blood score. He's just had a bleed. You cannot anticoagulate. It is not uncommon. If you actually think about it, you will get a lot of these patients from time to time in the general medical wards or perhaps in the geriatric wards. Very, very common. So we went ahead with fixing all in one go, which is we started with the PCI, fairly straightforward, did an OCT guided PCI. Once that was done, got venous access and did flutter ablation. Again, fairly straightforward. Because we want to combine all this, we used a heart navigator just to tell us where we are at any given point in time. And the flutter ablation was done. Once the flutter ablation was done, a transeptal was performed and the LA left atrium was sized after we make sure the LA pressures are 15 or 18. And then based on the LA size, we put an amulet there and close that. And that's the final LA appendage. And mind you, he had a high degree AV block. Now it's time to reverse the heparin because for this you need heparin. For the PCI you need heparin. Finish all the heparinized procedures first. And then if you want to reverse, you can reverse, or if you're comfortable doing it with an ACT of 150 like what we do, you can do the pacemakers, the last procedure, combining a device therapy. Therefore, this patient can have had a coronary intervention, EP, structure intervention, and device therapy. This is not an uncommon scenario, but there's one-stop solution, value-added addition to a patient where LA appendage closure can give a long-term better outcome without having the adverse effects of bleeding can be a good process for many patients. So I will conclude there. I think LA appendage closure along with ablation is safe, feasible, and is evidence-based. There's nothing to discuss much about it. It's very, very time-tested. This one-stop solution might be an aspect to consider, because in one procedure you get both, and it's value added. You minimize strokes, no anticoagulation, and the symptoms of arrhythmia is also gone from the AF ablation. Whilst I'm here, I thought I will just let you know about India Valves, because you're all here for structural learning. India Valves is a structural conference largely on valves. This is the largest national conference. This is September 12 to 14. It's in Chennai. Please mark your dates. This time it's all going to be based on app. You need to download an app. Without an app, nothing happens inside India Valves this time. And we're going to have some amazing aspects. For the first time in the history of our country, we're going to have a structural fellowship in Australia. The interview, selection, and the candidate is going to be at India Valves for the best case presenter. So that's a very good thing. You get a fully funded fellowship for Australia, whereby the interview is going to take place at India Valves. It's a very good thing. So please be there, and I look forward to seeing you there. Thank you.
Gopi always amazes me for doing multiple one-stop shop solutions. Fantastic. I think this is really, I mean, for the patient, it is a great benefit to combine two procedures. So I think this is being tested now in a clinical study, which we were part of as well, and the results will be presented probably within a year. Option trial. So it looked at all post AFib or AFib flutter patients, ablation, and post ablation concomitant, meaning the same time, or actually in a day later, we can do a left atrial appendage closure. And so that actually the results will be out. Hopefully, I think that will address payment in the United States, because when we're doing two procedures, we get paid only for one. So whether this will help us to say that this patient can actually, cost effectiveness wise, it will be much better for the insurance payers to just combine them in one, because they're paying for procedure costs, which is not a small amount. And for here, I think even here, procedural cost will be reduced if the patient has to come for one procedure compared to four.
Absolutely. And that's the whole idea. It's very cost effective, because you're anyway in the LA, your transeptal cost is one, your cath lab cost is one, your heparin cost, everything is one, your nursing is one, your ICU is one. Here, we're trying to minimize costs and maximize benefit.
Right.
So I think in India, this one-stop solution will be the way forward, because for the patient, it's very difficult to counsel a patient, I'm going to do an LA appendage. You won't feel any better. So
yeah,
it's very difficult. You can do a TAVR for 25 lakhs, no problem.
Right.
But if you want to counsel for an LA appendage closure for 5-6 lakhs, very, very difficult. The only person who I know, manages to counsel everyone is Ranjan Shetty. I don't know how he managed to get so many LA appendage closures. We can't, we just do it as an add-on, more as a value-added benefit, and that really works, and that I thought I'll share with others.
That's what we were sharing yesterday and today, that this whole meeting is about having, finding champions from these 250 people who attended to become the next pioneers and champions of their own, from their own institutions, on counseling and counseling patients, and trying to make this therapy, obviously therapy awareness is a must. In the United States, we run therapy awareness programs. We go to internal medicine doctors. We actually talk to the patients as well, and trying to make them understand that one stroke can actually change the entire family or the patient's outcomes, right? A person who's the breadwinning person in the family, if he has a stroke, everybody is going to be affected, unfortunately. So I think with that, thank you very much, Gopi, and we're looking forward to seeing you at India Valves. One last question, sir.
Yeah.
One question.
Sorry.
Sir, if the patient have only atrial flutter, if the patient has no fibrillation, only flutter, when the contractility is good, will you plan at that time for L appendage closure?
I'll just repeat your question.
Sir, I'm going
to repeat your question so that others follow. So the question is, if somebody had atrial flutter, like the one I had, they probably have very good atrial contraction, LA appendage contraction, would you still go ahead and do a LA appendage closure because the stroke risk is minimized? That's the question. The answer to that is electrophysiologically, flutter comes from AF. That's the general principle. Because if you have flutter, you will have AF. Flutters usually because of ectopy from the atrium, and If you have flutter, if you ablate flutter, almost certainly at some point you'll have atrial fibrillation. Flutter only happens because you have a very organized circuit in the right atrium. So if a short period of AF comes, quickly you will organize into atrial flutter if you have a short conduction time with the CTI. But it doesn't mean that you will not get AF. So if somebody has flutter, the risk of stroke is there, but not as much as atrial fibrillation. But the risk of stroke is not going to be negated because you just had flutter, you managed to just ablate flutter. So no. But even if you have atrial fibrillation, if you ablate it, you're still going to get a stroke. So no wonder if you have flutter and if you ablated flutter, it doesn't mean they're not going to get stroke from AF. So that's the rationale behind flutter, as good as AF. So you can close the LA appendage, even though you don't have an ECG showing atrial fibrillation. Answer?
Thank you very much. Any other questions before we let Gopi leave and Dr. Ranjan Shetty is going to come on stage?
Thank you, Dr. A.B. Gopalamurugan, sir, for your informative talk. I would request Dr. Ramesh, Head of Department of Cardiology, Sri Ramachandra Medical College, Chennai, to come on stage to give memento to Dr. Ragini Divedi, Dr. Edwin Francis, and A.B. Gopala Murugan, sir. Please join on stage. Dr. Ragini, Dr. Edwin Francis, Dr. A.B. Gopala Murugan, sir.
So can you bring the sound down? Yes. Thank you very much for everyone who have joined for the whole one day, yesterday half a day, and today's half day symposium. We just wanted to see before we go for the vote of thanks. I wanted to ask any suggestions from our audience here. Can you please pass the mics around? So most of the successful programs will be based on the constructive criticism from the audience. We want to do the programs for you. We design our content for you. If you did not like something, we want to change that. So
that TE simulation was a wonderful concept, and that is the first step in identifying the suitability and what device. So it should be made available to more doctors in other cities also.
Correct.
So is there any way we can, percolate this? Because that's the first step in percolating the device acceptability by doctors as well as patients.
Yeah. So just to, thank you for that suggestion. And just to add on, 100 people from the audience have actually undergone TE simulation in this conference handled by Dr. Kavya and Dr. Satish Govind. And most of them have liked it. What we thought is next year, we'll also get a demo where they can do septal puncture or, we'll try to get it. Right now, the simulator is quite expensive. It's on rent. So we had to get, even on rent, it was not available easily. We had to work. It's quite expensive, actually. I mean, if I have to tell you the amount, it is, the single day it costs 2.5 lakh. That's the expense of that simulator. Yeah. But we want all of you to have that experience. I'm happy you all took this interest. We'll take this in mind. Maybe have one more hall with all the simulation. And we have time. We'll work on that. This is going to be a yearly event. We want more feedbacks. We want all of you to join. And also Dr. Ramesh has a, precondition for next year.
yeah, so yeah, I already preconditioned. We at least need 10 champions.
Yeah.
And those 10 champions will be actually inducted as the faculty for the next year's session.
Yeah.
So the 10 champions will be considered as a champion after doing 10 left atrial appendage closures in 1 year. From this year to the next one.
Yes. Can we have volunteers for 10 champions? I can name one, Mukul. Yeah. One more champion. Yes. Well, can you tell your name, sir, Mike?
The mic is over there.
Yeah, from this one. Yes. 8 more slots.
I think even pediatric cardiologists
Yes,
can
yes,
start with
yes.
Dr. Srinivas and Dr. Anil Singhi.
Yeah. So, I mean, I think therapy awareness is important, and I'll tell you, this is something that is, we, I think, ignore certain things. We think that it doesn't matter, but it matters for the patient once we explain to them what actually can a stroke do to them or their family. So that therapy awareness has to be brought on. And looking at the patients who are intolerant to anticoagulation, who have kidney disease, who have GI bleeding, who have neurology or ischemic stroke with conversion to hemorrhagic or hemorrhagic strokes, all those patients are eligible. So please look and be on the lookout for these patients and conduct your own small workshops, including all these referring doctors, and educate them as well. I think one feedback.
So the TE
Chinmay?
simulation, the TE simulation sessions were very good, sir. So next year, if we can have something on ice also, the image orientations and a simulator if possible.
Yes.
Because most of us in India are not acquainted with ice. TE is something that we have been doing for some time.
Definitely, that's wonderful.
Very good suggestion. Are you all okay with this Friday half day, Saturday half day kind of this one, these dates? That's what, we
They can
we're
attend
trying
two
to keep
conferences.
Sunday off and try to do it on Friday, Saturday. Yes, yeah.
Okay, any other suggestions?
For beginners, what device you recommend to start with?
Yeah. So nowadays all devices are safe.
Stick with
Any
one.
device here would work at 98.5. They're safe. There's no device which is bad. Only recommendation is first 10 cases learn on one device. That's all. Whatever is comfortable, they all have plus, they all have minus, but there is a learning curve for each of them. First 10, just stick to any one device. 11th one you choose, and also it's all, knowing to unknown, as I told earlier. Stick to any of them. There's obviously no preference.
Learn one device properly, and then sometimes because you have to do something differently. What you're doing in Watchman is probably actually not acceptable to do in other pacifier type, whether it is Lambre or Amulet. So even in our own institutions, we don't actually say that you do one today, one tomorrow. One, get comfortable, and then after once you're enough number of cases under your belt, you can have one Amulet, one Watchman, one Lambre in one day. It doesn't matter, but you know how to change.
This is exactly what we have done.
Yeah.
Started with one, moved on. Yeah.
So just one point. The simulator was excellent, but if you could have the device models of the various types,
Correct.
we could understand the structure and correlate that knowledge when we do it.
Yeah, we talked about that actually earlier when we were sitting next to each other in the podium, but that's what I think people need to feel these devices, and we'll tell the industry.
Yes. We'll work on that. Until then, I have some suggestion for you. In the sense, see, the key is probably septal puncture, and most people here do balloon mitral valvotomy. How many of you do BMV? Yeah, see, almost all of you do BMV. My suggestion would be, use DexMed, call your anesthetist, have a TE probe in. It doesn't cost much, doesn't risk the patient. Do the septal puncture for those patients. It's not necessary you need to learn septal puncture in LAA. And also, all those TEs, you image LAA and choose a device mentally. You don't do the device, but if it is Lambre, this would be the size. If it is Amulet, this is the size, just mentally. And that's how it works. See, just to add on, see, when we started TAVI, for example, it started coming early, but I started in 2017, but world over it was there. But moment we realized it is there, I started crossing aortic wall, measuring gradient. So that all AS basically, it's recommended. We were not doing it because we thought it didn't matter. So that step covered. Per close, you don't learn it on a TAVI patient, right? You learn it on other. So split your procedures, make it small. So all BME from now on, do a transeptal puncture. At least, 20, 25 of that, if you have done, that step is done.
That step is done.
Yeah, and that's the key step actually. Rest is like ASD device. There's not too much this one. So split it, learn it in different procedures you have. And any TE from today on, any TE, see what you did is a simulator TE, but all of you do at least 5-6 TEs a month for whatever reason. In your mind, imagine if I'm doing LA, you might be doing it for IE, but if I'm doing LA, where would I puncture? And how would I image the appendage. And if it is this device, how would I do? And that's the way we did it. Yeah.
So,
Suggestion, one
excellent
more.
conference. My suggestion is just keep the same format that you have, because this reiteration of important points again and again across all the sessions, I think it's a very, very excellent thing.
Yeah, yeah. Thank you. And
Can you
that
identify
really
yourself?
helps. Yeah.
I'm-
Makes it easy.
Yeah.
Yeah, you identify yourself, please.
Yeah, I'm Vivek Chaturvedi. Actually, I'm an electrophysiologist.
Okay,
Yeah.
wonderful.
He was
Thank you.
my SR and teacher.
Okay, wonderful. Yeah, we have to have actually more electrophysiologists in the room as well, because it's a partnership. In many centers in the United States, actually, Watchman procedures or left atrial appendage closure procedures are done as a partnership, both with an electrophysiologist and an interventional cardiologist.
And also, I think this meeting saw a lot of pediatric cardiologists, lot of interventionists, lot of electrophysiologists, managing. Yeah.
And echocardiographers are important. So,
Yes.
keep be very nice.
Yeah, yeah.
Dr. Ranjan Shetty has been very nice to Kavya for his own benefit. You
Yeah.
know,
So-
she hasn't slept in 2 days to make sure this program is a great
Yeah.
success. We
I
want
was-
to thank you very much, really, for making this program very successful.
I was telling I slept like a baby, but she didn't sleep, so it's important. Somebody takes the responsibility.
Thank you. And we'll hand it over to you for giving the vote of thanks. One more suggestion?
Yeah, one more suggestion.
Yeah.
Like most of the cases of atrial fibrillation or strokes, like hemorrhage or whatever, will be handled by the physicians. Okay, before sending to cardiologist, they will be starting the anticoagulants, all those things. Why not to have this awareness in APA forum, like physicians forum? That would be great.
Yeah. I think it's a very good suggestion. See, I think the one thing which we didn't work on is how to build the program in your center. Probably that's the most important. We'll definitely have a talk, get some neurologists. In our hospital, we had geriatricians who are convinced about the procedure, neurosurgeons, neurology. I think building a program is important. But for this procedure, unlike a PFO, you don't need a referral from a neurologist. It is AF who either can or can't take anticoagulation for whatever, or doesn't want to take. That's exactly how FDA writes it. Either they can't take or they don't want to take. There are a lot of so it's all our patient. I'm sure all of us see at least 10 AF a day. Ideally, even going by the conservative estimate, 10% of them need. So there is a patient every day who probably needs. We're not here to tell indication. You choose your indication. But whenever you want to do, we'll be happy to help you. Whenever you want to start the program, we'll be happy to help.
So I just want to quickly thank all of you, and because from the bottom of my heart, I think the program is successful due to Ranjan and Kavya, but also all the audience who are sitting here, and the entire team of Manipal marketing team that has supported, as well as our industry partners from different vendors and everyone who has been here. I have to leave, and that's why I'm giving this short vote of thanks. I'll hand over to Dr. Ranjan Shetty, who is going to be giving the detail. Thank you. Thank you.
Thank you all once again for being a part of LAAC Summit to 2024.
So
it's time to
I'll give you, don't worry. So thank you, and first of all, I think I have to thank Dr. Ramesh for agreeing, and it's been a real honor. We have been thinking about it, and we are just overwhelmed with the response. Whenever we called people, or a lot of people showed interest, there were more than 400 registration. We had to actually shut it because we didn't anticipate this number. So I'm very happy, but we are going to do it as a yearly event. The dates will be announced much in advance. It will not be clubbed with one more conference. So it's going to be only a pure LAAC, because I think it needs that much respect, at least this much, that we give a conference to LA. So now I think vote of thanks. I would start with thanking all of you, because no conference can be done without the people participating. Thank you. The other important person to thank is Dr. Ramesh. We spoke. He spent, I think, his whole of his time in the podium, in and out, hardly had any time to have food. Dr. Kavya, who has actually literally spent sleepless nights. And if you see, the one thing which comes up in the conference also is the workshop, the simulator and the workshop. believe me, it was a very last moment addition because we were trying to find simulator. We just couldn't find it, but we knew this is very important. We will work on increasing it, just like all your suggestion. We would have more different kind of simulator overlap with the fluoro if possible, because we have some time now. Cadaveric lab at some point, we'll work on all that, and we'll also be conducting some more workshops in our center and Dr. Purohit center. The other thing which we thought we must have is a registry. From today to the next conference, whatever case we do, let's document it. Let's see the CHADVAS score. Let's see what was the indication, what device was used, what was the size, and if possible, let's follow them up. Maybe a TE on 45th day and a TE on 6 months. These two. 45th normal, then you don't need a TE on 6 months. Otherwise, 45th and 6 months to look at peri-device leak. Let's do that, and that should be one. Now, the conference definitely wouldn't have been possible without the help of my institute, which is Manipal Hospital. We share a common wall. Most of you must have seen the hospital. They've done a tremendous job, especially Mr. Mallikarjun. Is he here? Yeah, he's done tremendous job, and in organizing, in calling, in having. It's been amazing to have him work with. So all we have to do is, decide. He stayed maybe till 2 o'clock on the previous day of the conference to do this. He's here. Do we have a memento for Mallikarjun? Yeah. Kavya, new put. New Kodi. Yes. So he's done a great job with all his staff. Come. And look at the sheer strength which Manipal brings in. Anybody, almost all those white shirts are Manipal Hospital, and this is their marketing team. They put a lot of effort in coordinating and bringing people together. Yes. I think if you put the actual ratio, it is at 1:1. No? So, yeah. Give it. Yes. Congress. Thank you. Yeah. Thank you. Yeah. Photo ತೆಗ್ದ್ರಾ? Yeah. Thank you. Take a lot more photos. Not over. Thank you. Yes. So the group, thank you. We'll take more photos later. So other group, I think, which is, without sponsors, no program is possible, and definitely not at the magnitude of the program which we had. So we had a lot of sponsors. Some of them don't even make LAAC. So they have been sponsors because you are all the cardiologists, and we have such group of distinguished cardiologists, so they want to be part. So we have obviously Boston Scientific and Life Tech and Abbott, who have participated in a big way. You have all seen their stall. We also have a lot of pharma who have partnered and who have promised to partner even next year, because we are going to make it at least double this size next year, more in every way. So we have Novo Nordisk, Cipla, Smart Cardia, then Web Cardio, AstraZeneca, Philips, Wipro, Alembic Pharma, Thermo India, Lupin, Dr. Reddy's, Sun Pharma, Pfizer, and USP, and Mont Healthcare. So the big list. I thank each of you for participating and contributing, and thank you very much. We'll give this a thank you. And so other So the conference of this kind is just not possible without a team. So I'm happy to say that we have a good team in cardiology. You know Kavya, and you also we have Surya and Lakshmi, who are twin brothers, who are fellows with us, and they have been coordinating. One of them coordinating, the travel transport, and they have been very quick with the other one actually managing this. And today happens to be their birthday. So we're going to cut a cake for them here if you all come. Yeah. Can you make out the twins? Come, come, come. Yeah. Since they're twins, they can feed each other. Yeah. No, each other. Yeah. Yeah. But they really put lot of hard work. I'm sure most of you know them by name this time. Yeah. Yeah. Thank you. Yeah. We'll have later. No, thank you. Yeah. And then we have Rajesh and Sneha and others who have been part of our team, who have worked very hard. And I want to personally thank the hotel, the GM, Mr. Arya, Madhu, the manager, and all of them, because they've gone out of the way to help us. The whole hotel has been ours. We have taken a lot of rooms, first floor, second floor, everything has been ours. And I really thank them. All of you must have realized their hospitality was amazing, and they've always been helpful, and I'm eternally thankful to them. So thank you one and all. Hope to meet you next year sometime. Lunch will be served. Have lunch, and then maybe we can disperse. And if anybody's staying back, please stay. There are people staying back. Enjoy Bangalore. Stay around. Have a good time. Bye. Bye. And also, where is lunch I've told, yeah. And this journey for me personally, LAA, is been with Satya. He was involved in both the companies. I thank Satya, I thank Usri and Angelina. This is beyond their, support as the financial support. Thank you. I thank Dr. Iyengar and Dr. Patil who are here. Yeah. Thank you, sir. Thank you. Thank Sorry, lunch is served here in this room. Yeah, lunch is served here. Please have lunch here. Yeah. ಆಗುತ್ತಾ ಎಲ್ರಿಗೂ ಇಲ್ಲಿ ಕೊಡೋಣ ಬನ್ನಿ.
accordingly.